Looks. Fibroadenoma. These things are classically T2 bright, round, with non-enhancing septa, and a type I curve. DCIS, clumped, ductal, linear or segmental non-mass likely enhancement. Kinetics are typically not helpful for DCIS. IDC, spiculated irregular shaped masses, with heterogeneous enhancement and a type 3 curve. ILC, doesn't always show enhancement. Fibroadenoma, non-enhancing septations DCIS, segmental NMLE IDC, spiculated, with type 3 curve. T2 bright things. Usually T2 bright equals benign. Things that are T2 bright include cysts, lymph nodes, fat necrosis, fibroadenoma. The exception, anytime I say the word except you need to think high yield, colloid cancer, and mucinous cancer can be T2 bright. 391. Pure trivia. If you have a patient with known breast CA, how often do you find a contralateral breast CA? Answer is 0.1 to 2% via mammogram, and 3 to 5% by MRJ. Never BR, 0 an MRI case. This is as much workup as you are going to get, so just call it benign or biopsy it. You can actually BR, 0 something if you really want to prevent a biopsy, possible lymph node, US, and mammo to confirm benign sorta situation. This is still kinda weak. For the purpose of multiple choice, think twice before you BR, 0 a MRI case. Spiculated margins equals 80% malignancy. This is the single most predictive feature of malignancy. 392. LL. Section 15, risk. Estrogen 11 related, the more exposure to estrogen the higher your risk of breast cancer will be. Anything that prolongs this exposure is said to increase risk. For example, an early age to begin menstruating or a late age to have menopause. Hormone replacement therapy with estrogen alone obviously increases exposure. Early maturation of lobules, which can be achieved by getting pregnant young, reduces your risk. Being fat increases estrogen exposure, more aromatase equals more estrogen. Being a drunk increases estrogen exposure via messing with its normal breakdown. In the liver, estrogen-elated risks 1. Early menstruation, III late menopause, L late age of first pregnancy, I or no kids. L being fat, I being a drunk, I hormone replacement with estrogen. L. High-risk lesions, any of the high-risk lesions, ADH, ALH, LCIS, radial scar, papilloma, are associated with an increased risk. These are discussed more in detail later in the chapter. Density is considered a medium risk, and is dose-dependent with the denser you are the more risk you have. Chest wall radiation, usually seen in lymphoma patients, is a big risk. Especially at a young age. The risk is supposed to peak around 15 years post-treatment. If the child had more than 20 GY to the chest, she is going to qualify for an annual screening MRI at age 25 or 8-year post-exposure, whichever is later. Relatives with cancer, a first-degree relative with breast cancer increases your lifetime risk from 8% to 13%. 2 first-degree relatives increases your risk to 21%. A 1 BRCA1 chromosome 17. More common than type 2. Increased NSK-I1 for breast, ovary, and various GI cancers. IBRCA2 chromosome 13. Male carrier. Actual mutations. Breast cancer risk models. There are several risk models, which have pros/cons and differences. I apologize in advance for even suggesting you learn about these. But it just seems testable to me. I'm sorry. Gale model validated breast cancer risk factors, biopsy of IA. It's too old school. I oldest and most focuses PE son __ NT use genety 1. Risk model ADH and family I only validated in 1 IA history African Americans. I factors. Tyricus IKST comprehensive, includes personal I does not include risk, biopsy with I breast density. L _____________________________________________________________________________________________________________________ IADH or LCIS _J_J_____ family history ____________ High yield take home points regarding RIK. Anything that gets you more estrogen increases your risk. BRCA1 is more common than BRCA2 in women. Men with BRCA2 get more cancer than men with BRCA1. Breast density is an independent risk factor. Denser the breast, the more the risk. 20 GY of radiation to your chest as a kid buys you a screening MRI at 25 or 8 years after exposure, asterisk whichever is longer, Cowden syndrome, bowel hamartoma, follicular thyroid cancer, Lermite de Clos, and breast cancer. All current risk models underestimate lifetime risk. Tyrer-Cuzick is the most comprehensive risk model, but does not include breast density. Exercise, probably more like not being fat, reduces the risk of breast cancer. Tamoxifen and raloxifene, SERMs, reduce breast cancer incidence of ER/PR positive cancers. Mortality may not actually be reduced. Sound familiar? 394. LLL. L. Screening controversy. Gilbert Welch, how dare you use math? Recent large heavily powered studies have brought into question the practice of screening mammograms. I highly recommend you read these /Kessable papers, but please wait till after the exam, because the people who write multiple choice questions about mammography are definitely not the same people who wrote these papers. For the purpose of multiple choice tests, screening mammography saves lots of lives. You should buy pink ribbons, and low-grade DCIS in a 95-year-old needs a surgical consult. Blyer, Archie, and H. Gilbert Welch. Effect of 3 decades of screening mammography on breast cancer incidence. New and 1-11D Journal F Medicine 367.21, 2012, 1998-2005. Miller, Anthony B. ETAL, 25-year G, low up for breast cancer incidence and mortality of the Canadian National Breast Screening Study, randomized screening trial. BMI, British A1 Ethical Journal 348, 201-1. 395. Section 16, ACR appropriateness. These all make great next step questions. Remember, scoring is 1 to 9, with 9 being the most appropriate and 1 being the least. Breast cancer screening, variant 1, high-risk women. BRCA, plus untested first-degree relatives, history of chest radiation, risk model showing 20% of greater lifetime risk. Mammo, highly appropriate, 9, beginning at age 25 to 30, or I 0 years before age of first-degree relative with breast cancer, 8 years after radiation therapy, but not before age of 25. Mammography and MRL. They are complementary examinations, both should be performed. Tomosynthesis, highly appropriate, 9, beginning at age 25 to 30, or I 0 years before age of first-degree relative with breast cancer, 8 years after radiation therapy, but not before age of 25. Mammography and MRI. They are complementary examinations, both should be performed. MRI, highly appropriate, 9, mammography and MRI. They are complementary examinations, both should be performed. Variant 2, medium risk women. Women with person history of breast CA, lobular hyperplasia, atypical ductal hyperplasia, or risk model showing 15 to 20% lifetime risk. Mammo and Torno are 9s, MRF is a 7. Mammography and MRI. They are complementary examinations, MRI should not replace mammography. Variant 3, average risk women. Women with 15% lifetime risk. Mammo and Torno are 9s, MRI is a 3, which means it's not appropriate. 396. L. Breast pain, variant I, cyclical, unilateral or bilateral. Age 40. No imaging is appropriate. Ultrasound is the least inappropriate and it's rated at a 2. Variant 2, cyclical, unilateral or bilateral. Age 40. No imaging is appropriate. Ultrasound, Mammo and Torno are the least inappropriate and all rated at a 2. Variant 3, non-cyclical, unilateral or bilateral. Age 40. Ultrasound might be appropriate and is rated as a 5. Stage 1 breast CA, initial workup and surveillance, no symptoms. Newly diagnosed, rule out mets to the bones, chest, liver and / or brain. No imaging is appropriate. CT, MRJ, PET etc., not indicated with initial stage I. Surveillance I rule out local recurrence. Diagnostic Mammo or Torno is appropriate and is rated as a 9. Ultrasound might be appropriate and is rated as a 5. MRI might be appropriate and is rated as a 5. 397. Symptomatic male breast. Variant 1, any age with physical exam and history consistent with gynecomastia or pseudogynecomastia, bitch tits. No imaging is appropriate. Variant 2, less than 25 years old with indeterminate palpable. Ultrasound is appropriate and is rated as a 8. Mammo is in the may be appropriate category as a 5. L would only do this if the ultrasound doesn't answer your question. Variant 3, more than 25 years old with indeterminate palpable. Mammo is appropriate and is rated as an 8. Ultrasound is in the may be appropriate category as a 5. Variant 4, more than 25 years old with indeterminate palpable. The mammogram was indeterminate or suspicious. Ultrasound is appropriate and is rated as a 9. Variant 5, physical exam is highly concerning for cancer. Dude has an ulcerative mass, axillary nodes, nipple retraction, etc. Mammo is appropriate and is rated as a 9. Ultrasound is appropriate and is rated as an 8 to stage the breast and axilla just like a female breast CA workup. 398. LL. Random situations, first/next step. Women 40 with palpable mammo is appropriate and is rated as a 9. Women 40 with mammo suspicious for CA ultrasound is appropriate and is rated as a 9. Women 40 with mammo findings of a lipoma at the site of a palpable. No imaging is appropriate. Women 40 with palpable findings and a negative mammo ultrasound is appropriate and is rated as a 9. Women 30 initial evaluation ultrasound is appropriate and is rated as a 9. Women 30 to 39 initial evaluation ultrasound is appropriate and is rated as a 8. Mammo is appropriate and is rated as a 8. Women 30 ultrasound is suspicious for CA core biopsy is appropriate and is rated as a 9. Mammo is appropriate and is rated as a 8. Women 30 ultrasound is negative, no imaging is appropriate. Women 30 ultrasound has a benign finding, like a cyst, no imaging is appropriate. Women 30 ultrasound is BR3 able, example fibroadenoma. Short interval follow-up, usually Q6 months x 2 years. 399. SEC110N11 procedures. The most common procedures are going to be ultrasound-guided and stereotactic biopsy of masses and calcification. I'll try and touch on the testable points. Ultrasound. Overall ultrasound is faster and easier than stereo. If you can see the mass under US, you should do the biopsy under US. Usually a 14-gauge automatic spring-loaded device is used for masses. You should put the mass on the far side of the US screen. Lets you see the length of the needle better. Ideally for things should line up during the biopsy. The lesion, the transducer, the skin nick, and the biopsy needle. The needle angle should be parallel to the chest wall. The pneumothorax is an embarrassing complication of a breast biopsy. Anesthetic should be placed right up to but not into the lesion. Especially when the lesions are small. You should try and biopsy the deeper part of a lesion first. If you obscure it from bleeding, at least you can still get the top part. If you have 2 lesions to biopsy, try and hit the smaller one first. If the bigger one bleeds, it may obscure the smaller one. It's less likely the other way around. If you have a solid and cystic lesion, you should biopsy the solid part. About 90% of the time, you can make a diagnosis off 1 or 2 passes, though most texts still recommend doing 5. Next step scenario, like an idiot you injected a bunch of air around the mass, while you were trying to give lidocaine. Now you can't see the mass. What do? You have to reschedule. Don't try and biopsy it blind. Axil/A, when you biopsy axillary lymph nodes you should target the node's cortex. Core biopsy is preferred over FNA if you have no clue what it is. If you have known breast cancer and you are nearly certain you are dealing with a MET, FNA works fine. 400. L. Special scenario, the cyst aspiration. Indications, anxiety, pain, uncertain diagnosis. Size is not an indication for aspiration. Cysts recur about 70% of the time. This drops to around 15% if you inject air after you aspirate. The hypoechoic mass vs dirty cyst scenario, classic. Next steps. Next step scenario #I. You suspect a hypoechoic mass is a debris-filled cyst rather than a solid mass, but you aren't totally sure. What should you do first? Aspirate it. Next step scenario number 2, same hypoechoic mass vs cyst, you aspirate it, and you get non-bloody fluid. You also notice the lesion disappeared. What do? You should pitch it. No need for cytology. You are done. Next step scenario 113, same hypoechoic mass vs cyst, you aspirate it, and you get bloody fluid. You also notice the lesion disappeared. What do? Send it to cytology, then place a clip. Next S1EP scenario number 4, same hypoechoic mass vs cyst, you aspirate it, and you get purulent poop-like fluid. The fluid smells like a zombie farted. You also notice the lesion disappeared. What do? Send it to the microbiology lab for culture and sensitivity. Next step scenario number 5, same hypoechoic mass vs cyst, you aspirate it, and you get fluid. You also notice the lesion does not disappear. What do? Proceed to core biopsy of the residual solid mass. 401. Stereotactic biopsy, using a mammogram to localize and target the lesion. This is the preferred move for calcifications. Typically the specimen is x-rayed after the sample to confirm there are calcifications within the biopsied tissue. Vacuum-assisted devices are typically done for calcifications. The biopsy is performed in compression, with slightly less pressure than a normal mammogram. Compressibility of the breast tissue cannot be less than 2 to 3 centimeters, some texts say 28 millimeters. Otherwise you risk throwing the needle through the other side of the breast into the digital receptor. This is called a negative stroke margin. Next step scenario, what if the breast compress is too small, 20 millimeters? You should do a wire localization for excisional biopsy. A marker, tiny piece of metal, should be placed after each biopsy. Clip migration can occur, accordion effect. You will need a mammogram in the orthogonal view to evaluate for this post-placement. QC, localization and accuracy test, to verify system alignment and performance, is performed daily before patient exams. 402. L. SEC110N1A, MQSA. The U.S. Food and Drug Administration Mammography Quality Standards Act, MQSA, yes that is a real thing, demands a medical audit and outcome analysis be performed once a year. You are forced to follow up patients with positive mammos and correlate pathology with biopsy results, so you can see how much benign disease you biopsy and how much fear, anxiety you generate. You have to grade the biopsy with the risk category. You can't accept benign results with a BR5. MQSA and other crap they could ask. 3 months of mammography is required during residency training. The recall rate should be less than 0%. Mammography facilities are required to provide patients with written results of their mammograms in language that is easy to understand, also known as a lay report, and must be given within 30 days of the study. A consumer complaint mechanism is required to be established in mammography facilities to provide patients with a process for addressing their concerns. Patients can obtain their original mammograms, not copies, when they are needed. For cases in which a facility's mammograms are determined to be substandard and a risk to public health, facilities will notify the patients and their doctors and suggest an appropriate plan of action. The interpreting physician is ultimately responsible for the quality control program. The required resolution of line pairs is 13 lp/mm in the anode to cathode direction and 11 pairs in the left-right direction. To make it pass image quality, must show for fibers, 3 microcalcification clusters and 3 masses plus acceptable artifacts. The dose phantom is 50% glandularity, 4.2 cm thick, and is supposed to have a dose less than 3 mgy per image plus grid. Don't get it twisted, there are no patient dose limits in mammography, only a phantom dose. A dense breast can result in a higher patient dose, which could easily exceed 3 mgy/view. Typical patient and phantom doses are about 2 mgy per view, or 4 mgy for a 2-view screening examination. The typical, average, compressed breast is 6 cm, glandularity of 15 to 20%. Digital systems generally uses higher beam qualities which results in lower doses. Digital mammography does not use fixed dose screen film, can use as much or little radiation as deemed appropriate. Male residents must urinate in the sitting position while on the mammography service. Standing urination is not allowed per MQSA. 403. Specific tasks that the test writers think you should memorize: localization, eye accuracy, for stereotactic biopsy, daily before patient exams, processor QC, daily darkroom cleanliness, daily viewbox conditions, weekly phantom evaluation, weekly repeat analysis, quarterly compression test, semi-annually darkroom fog, semi-annually screen film contrast, semi-annually. Appropriate target range for medical audit: recall rate 4 to 7% cancer, II000 screen 3 to 8. 404. RL. IL Section 19, Scenario I review. As I promised in the first pages of the chapter, I want to finish by rolling through some scenarios. This is mainly to demonstrate the workflow process and how you handle next step type questions. Scenario 1. A 40-year-old woman presents for her baseline screening mammogram. You have the great pleasure of reading it. While conducting your normal reading pattern, you notice the posterior nipple line is 9 cm on the MLO but only 6 cm on the CC. What do? There would be a technical callback. What BR? This is a BR0. Scenario 2A. A 50-year-old woman presents for her annual screening mammogram. You have the great pleasure of reading it. You notice a mass on 2 views in the lateral left breast. What BR? This is also BR0. Next step. Rhythm for diagnostic mammogram, including spot compression views and likely an ultrasound. Scenario 2B. Same patient returns for the diagnostic mammogram. You can clearly see the mass in 2 views. Next step. Ultrasound to further characterize scenario 2C. You put her in ultrasound and see an obvious shadowing, angry, pissed off mass that is ulcerating through the skin, etc. It L00% for sure cancer. Next step. You need to stage. Scan the rest of the breast for multifocal masses, and scan the axilla for pathologic nodes. Scenario 3A. A 50-year-old woman presents for her annual screening mammogram. You have the great pleasure of reading it. You notice what looks like a mass in the CC view, only can't find it in the MLO. You call it an asymmetry because you can only see it in one view. Next step. BR0 and bring it back with spot compression views. 405. Scenario 3B. Same patient returns for the diagnostic mammogram. After the paddle is applied, there does not appear to be any mass. It just looks like normal breast tissue. You look at prior imaging, and it looks pretty similar to the priors now. Next step. BRI and return to screening. This is the classic scenario of a does not persist callback. Scenario 4A. A 24-year-old male presents as with a palpable mass in his left breast. Next step. Mammogram, never ultrasound a male breast before you get a mammogram. Scenario 4B. A mammogram is obtained and shows a flame-shaped density under the nipple, correlating with the palpable marker. Next step. Interview the patient to see if you can come up for a reason for his gynecomastia, psych meds, marijuana use, etc. You don't want to miss a pituitary tumor. He tells you he smokes pot every day. You tell him that he is a very bad boy, even though there is no evidence that marijuana causes real harm, and its criminalization was based on false propaganda from the hemp industry. Scenario 4C. After you tell him he is a bad boy for smoking the sticky icky, he still seems worried. He tells you that he got an ultrasound at the outside hospital, and they told him he had breast cancer. He pulls a CD out of his pocket and asks you to look at it. You look at the outside images and sure enough there is a shadowing mass in the area of the palpable finding. Next step. BR2 gynecomastia. This is the oldest trick in the book. Gynecomastia looks like a scary mass on US, that's why you always start with the mammogram. Scenario SA. Screening mammogram is performed on a 70-year-old woman. Woman, who has a history of prior lumpectomy 4 years ago. You read in her chart that she refused radiation therapy. Next step. Rhythm for diagnostic mammogram, including spot compression views and likely an ultrasound. Scenario 2B, same patient returns for the diagnostic mammogram. You can clearly see the mass in 2 views. Next step. Ultrasound to further characterize scenario 2C. You put her in ultrasound and see an obvious shadowing angry pissed off mass that is ulcerating through the skin etc. It L00% for sure cancer. Next step. You need to stage. Scan the rest of the breast for multifocal masses and scan the axilla for pathologic nodes. Scenario 3A, a 50-year-old woman presents for her annual screening mammogram. You have the great pleasure of reading it. You notice what looks like a mass in the CC view only. Only can't find it in the MLO. You call it an asymmetry because you can only see it in one view. Next step. BR0 and bring it back with spot compression views. 405. Scenario 3B, same patient returns for the diagnostic mammogram. After the paddle is applied there does not appear to be any mass. It just looks looks like normal breast tissue. You look at prior imaging and it looks pretty similar to the priors now. Next step. BRI and return to screening. This is the classic scenario of a does not persist callback. Scenario 4A, a 24-year-old male presents as with a palpable mass in his left breast. Next step. Mammogram, never ultrasound a male breast before you get a mammogram. Scenario 4B, a mammogram is obtained and shows a flame-shaped density under the nipple, correlating with the palpable marker. Next step. Interview the patient to see if you can come up for a reason for his gynecomastia, psych meds, marijuana use, etc. You don't want to miss a pituitary tumor. He tells you he smokes pot every day. You tell him that he is a very bad boy, even though there is no evidence that marijuana causes real harm, and its criminalization was based on false propaganda from the hemp industry. Scenario 4C. After you tell him he is a bad boy for smoking the sticky icky, he still seems worried. He tells you that he got an ultrasound at the outside hospital, and they told him he had breast cancer. He pulls a CD out of his pocket and asks you to look at it. You look at the outside images and sure enough there is a shadowing mass in the area of the palpable finding. Next step. BR2 gynecomastia. This is the oldest trick in the book. Gynecomastia looks like a scary mass on US, that's why you always start with the mammogram. Scenario SA, screening mammogram is performed on a 70-year-old woman, who has a history of prior lumpectomy 4 years ago. You read in her chart that she refused radiation therapy. She heard on the news that radiation was bad, so she decided on a more holistic approach, bananas. She also gets yearly thermograms. The area of scarring dot in the resection bed looks more dense. Next step. BR0 and recall for spot compressions. Compressions. Scenario SB, the spot compressions show small calcifications in the area of the lumpectomy bed, and the scar is definitely more dense. Next step. MAG views to further characterize the calcifications. You decide they look pointy, so you call them fine pleomorphic. Scenario SC, you stick her an ultrasound to be complete, it looks like a small mass. You stage the remainder of the breast and axillae, and it looks pretty clean. Diagnosis. BR5, local recurrence. 406. L. Blank for notes. 407. Blank for notes. 408. I_L. Chapter 15, Strategy, Prom Ethias Lionheart. Ethias Lionheart, MD. 409. There are 3 kinds of questions on multiple choice tests. 1. The ones you know, you want to get 0% of these right. 2. The ones you don't know, you want to get 25% of these right, same as a monkey guessing. 3. The ones you can figure out with some deep thought, you want to get 60 to 70% of these right. If you can do that, you will pass the test, especially if you've read my books. My recommendations: for the ones you know, just get them right. For the ones you don't know, just say to yourself, this is one I don't know. Prometheus says just try and narrow it down and guess. For the ones you think you can figure out, mark them and go through the entire exam. If you follow my suggestion on the first 2 types of questions, you will have ample time left over for head scratching. Other reasons to go ahead and do the whole exam before trying to figure them out is: A. You don't want to rush on the questions you can get right, and B. Sometimes you will see a case that reminds you of what the answer is. In fact, it's not impossible that the stem of another question flat out tells you the answer to a previous question. Let your plans be dark and impenetrable as night, and when you move, fall like a thunderbolt. Sun Tzu. 410. L. A. Studying for AC. For many of you, this is the first time you truly do not need an A on the exam. I can remember in undergrad and medical school feeling like I needed to get every question right on the exam to maintain my total and complete dominance. I felt like if I missed a single question that I wouldn't honor the class, I wouldn't match radiology, and I'd end up in rural West Virginia checking diabetic feet for ulcers in my family medicine clinic. The very thought of a career in family medicine was so horrible that I'd begin to panic. Panic doesn't help. Truly, this exam is not like that. You can miss questions. You will miss questions. You can miss a lot of questions. You just need to miss less than about 10% of the room. No matter what they tell you, no matter what you read, all standardized exams are curved. If they passed 100%, the exam would be called a joke. If they failed 50%, the program directors would riot, after first punishing the residents with extra call. The exam will maintain a failure rate around 10 to 15%. What that means is that you only need to beat 10 to 15% of the room. You don't need 99th percentile. There is no reward for that. You need 16th percentile. 16th percentile is AC, that is the goal. The reason I'm perseverating on this is that you need to avoid panic. If you mark 20 to 30% of the questions as not sure, or Promethean category 2 or 3, you might begin to freak out. Especially if the inner gunner medical student in you thinks you won't get honors. Chill out. It's okay to miss questions. Look around the room and know that you studied harder and are smarter than 15% of the room. Do not flee the exam in tears. Fate rarely calls upon us at a moment of our choosing. Opturnus Prime. 411. Exploiting the genius neuron. Have you ever heard someone in case conference take a case and lead with "it's not this," when clearly this is what the case was? It happens all the time. Often the first thing out of people's mouths is actually the right answer, but many times you hear people say, "it's not" first. Ever wondered why? I have this idea of a genius neuron. You have one neuron that is superior to the rest. This guy fires faster and is more reliable than his peers, and because of this he is hated by them. He is the guy in the front row waving his hand shouting, "I know the answer." You know that guy is a notorious asshole. So, in your mind he shouts out the answer first, and then the rest of the neurons gang up on him and try and talk him out of it. So the end product is "it's not this." For the purpose of taking cases in conference, this is why you should always lead with "this comes to mind" instead of "it's not." Now, the practical piece of advice I want to give you is to trust your genius neuron. Serious, there is a lot of material on this test. But if you read this book, there will be enough knowledge to pass the test existing somewhere between your ears. You just have to trust that genius neuron. How? Do it like this. 1. Read the entire question. Look at all the pictures. 2. Read all the answer choices. Never stop at a thinking that is the answer. 3. Look again at all the pictures, now that you see the choices. 4. Choose the first answer your mind tells you is correct, the one your genius neuron thinks it correct. 5. After you have finished the test, and you are re-reviewing your answers, never change the genius neuron's answer except for 2 criteria: the question wrong. B. You are 0% sure that it is another choice, and you can give a reason why. Never change based on your gut feelings. Those secondary gut feelings are the stupid neurons trying to gang up on the smart one. Just like in the real world, the stupid people significantly outnumber the smart ones. I'll know this sounds silly, but I really believe in this. This is a real thing. I encourage you to try it with some practice questions. You either believe in yourself or you don't. Captain James T. Kirk. 412. Dealing with the linked question. It is a modem trend for multiple choice tests to have linked questions. You may remember that USMLE Step 3 had them, and it is rumored that the core exam has them as well. These are the questions that prompt you with "this is your final answer, you can't change your answer." When you see this, stop. If you are 100% sure you are right, then go on. If you had it narrowed down to 2 choices, think about which one would be easier to write a follow-up question about. This might seem obvious, but in the heat of the battle you might get too aggressive. Slow down and think twice on these. The second point I want to make about these questions is finding some zen if you miss it. There are a lot of questions on this test, it's okay to miss some. You will still pass, probably. People like you have always studied for the A+, not the C. So when you miss a question it makes you freak out because you think you blew it. You don't need an A in this time. You don't need a B. You just need to pass so they don't get any more money from you. Believe me, they have taken enough from you already. I just want you to understand that you will miss questions and it's okay. If the second part reveals that you dropped one, don't let it faze you. Just do your best. The most important fight is always your next one. ISN 1 The mountains ahead low climb hill wears you out. S the pebble in your shoe. Muhammad Ali. 413. It's possible to know too much. If you were to begin studying and begin taking multiple choice practice questions, and you plotted your progress as you gained more knowledge, you would notice something funny. At first you would begin to get more and more questions right. And then you would start to miss them. Q.0, pound colon colon. 0 Q, C. E. Colon colon colon. C0 T5 Q, 00 slash Q, and C. J. Knowledge. Well, how can that be? I will tell you that once you know enough, all choices on the exam become correction. Which of the following can occur? Well, actually they can all occur. I've read case reports of blah blah blah. That is what happens. The trick is to not overthink things. Once you've achieved a certain level of knowledge, if they give you a gift, take it. It's usually not a trick, usually. Don't look for obscure situations when things are true. Yes, it's possible for you to know more than the person writing the questions. Yes. I said it and it's fucking true. These people don't know everything. You can out-knowledge them if you study enough, and that is when you get yourself into trouble. Take home point, once you've reached the peak, arrow on chart, be careful overthinking questions past that point. Always remember, your focus determines your reality. Jedi Master Qui-Gon Jinn. 414. R. 6 Promethean laws for multiple choice. Number 1, if you have a gut feeling, go for it. Trust the genius neuron. Number 2, don't overthink to the extent that you veer from a reflexive answer, especially if choices seem equally plausible, you can know too much. Number 3, read all the choices carefully. Number 4, if it seems too obvious to be true, trickery, reread it, and then go with it even if it seems too easy. Let it happen, it's usually not a trick, usually. Number 5, add up what you know, and compare with what you think you know. Weight your answers by what you know. Number 6, most importantly, don't panic. Maybe I can't win, maybe the only thing I can do is just take everything he.s got. But to beat me, he's gonna have to kill me, and to kill me, he's gonna have to have the heart to stand in front of me, and to do that, he.s has to be willing to die himself. Rocky Balboa. 415. SECR10N1 PEDS. Why are you showing me a lateral soft tissue neck x-ray? This could be shown for 2 main reasons. 1, the thumb sign of epiglottis, or 2, the super wide prevertebral soft tissues for retropharyngeal abscess. Epiglottitis, thumb sign retropharyngeal abscess. Why are you showing me an ultrasound of the neck? In PEDS this can only be a few things. Fibromatosis coli is probably the most common thing shown, mass-like fibrosis of the stemocleidomastoid muscle. Jugular vein thrombosis, think Lemire syndrome, chest will have septic emboli. Fusobacterium necrophorum is responsible for a majority of cases. Cysts if midline, think thyroglossal cyst. If lateral, think branchial cleft cyst. Fibromatosis coli, 2 heads of the sternocleidomastoid. 416. NG tube tricks. Why are you showing me an ultrasound of the neck? In PEDS this can only be a few things. Fibromatosis coli is probably the most common. SECR10N1 PEDS. Why are you showing me a lateral soft tissue neck x-ray? This could be shown for 2 main reasons. 1, the thumb sign of epiglottis, or 2, the super wide prevertebral soft tissues for retropharyngeal abscess. Epiglottitis, thumb sign retropharyngeal abscess. Why are you showing me an ultrasound of of the neck. In peds this can only be a few things. Fibromatosis coli is probably the most common thing shown, mass-like fibrosis of the stemocleidomastoid muscle. Jugular vein thrombosis, think Lemierre syndrome, chest will have septic emboli. Fusobacterium necrophorum is responsible for a majority of cases. Cysts if midline think thyroglossal cyst. If lateral think branchial cleft cyst. Fibromatosis coli, 2 heads of the sternocleidomastoid. 416. NG tube tricks, the presence of an NG tube, especially if not placed correctly, should alert you to some form of trickery. The NG tube stops in the upper thoracic esophagus, think esophageal atresia, probably in the setting of VACTERL. The NG tube curling into the chest, it's either 1, in the lung, or 2, it's in a congenital diaphragmatic hernia. If I had to pick between the two, and it wasn't obvious, I'd say left side hernia, right side lung just because those are the more common sides. NG tube curls in the upper thoracic esophagus. First think esophageal atresia. Then think VACTERL. The classic congenital lobar emphysema trick, they can show you a series of CXRs. The first one has an opacity in the lung, the affected lung is fluid-filled. The next X-ray will show the opacity resolved. The following X-ray will show it getting more lucent and more lucent. Until it's actually pushing the heart over. This is the classic way to show it in case conference or case books. The mandible, there are only a few things that a mandible will be shown for with regards to peds. Think Caffey's first, especially if the picture looks blurry and old, there hasn't been a case of this in 50 years. If it's osteonecrosis think about OJ. On bisphosphonates. If it's a dwarf case, think wide-angled mandible with pycnodysostosis. A floating tooth could be e.g. 417. The school-age CXR, things to look for. Big heart, probably showing you a sickle cell case. Look for bone infarcts in shoulders. Lucent lung, think foreign body, air trapping. Remember you put the affected side down, if it remains lucent that confirms it. The abdominal plain film, on a newborn problem-solving bubbles. Pattern path next step single bubble, in a newborn this is This is gastric, antral or pyloric atresia. In an older child, think gastric volvulus double bubble duodenal atresia. Triple bubble jejuna. Atresia. Single bubble plus distal gas concern for mid-gut. Next step equals upper GI plus bilious vomiting volvulus. Multiple dilated loops concern for lower next. Step equals contrast enema obstruction. Step equals contrast enema obstruction. Heterotaxia, this can be inferred or asked several ways. Heterotaxia syndromes, right-sided 2 fissures, inhalful lung asplenia, increased cardiac malformations, reversed aorta/IVC. Left-sided 1 fissure in right lung polysplenia, less cardiac malformations, azygous continuation of the IVC. 418. This vs that, neonatal pneumonia and RDS can look similar, both with granular opacities. RDS should have low lung volumes, regular pneumonia will have increases. Increases. RDS is gonna be premature, if they give you that history. Lastly, pneumonia will often have a pleural effusion, which RDS will not. This vs that, cystic fibrosis vs primate ciliary dyskinesia. CF abnormal mucus, cilia can't clear it, bronchiectasis, upper lobes, normal sperm, obliterated vas deferens. Dash, normal sperm, obliterated vas deferens. This vs that, vascular impressions. D. 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 When I say this, you say that. When I say subglottic hemangioma, you say Fass's syndrome. When I say Fass's syndrome, you say cutaneous hemangioma. When I say ropey appearance, you say meconium aspiration. When I say post-term delivery, you say meconium aspiration. When I say fluid in the fissures, you say transient tachypnea. When I say history of C-section, you say transient tachypnea. When I say maternal sedation, you say transient tachypnea. When I say granular opacities and premature, you say RDS. When I say granular opacities and term and high lung volume, you say pneumonia. When I say granular opacities and term and low lung volume, you say B hemolytic strep. When I say band-like opacities, you say chronic lung disease, BPD. When I say linear lucencies, you say pulmonary interstitial emphysema. When I say pulmonary hypoplasia, you say diaphragmatic hernia. When I say lung cysts and nodules, you say LCH or papillomatoses. When I say lower lobe bronchiectasis, you say primary ciliary dyskinesia. When I say upper lobe bronchiectasis, you say CF. When I say posterior mediastinal mass under 2, you say neuroblastoma. When I say no air in the stomach, you say esophageal atresia. When I say excessive air in the stomach, you say H-type T fistula. When I say anterior esophageal impression, you say pulmonary sling. When I say pulmonary sling, you say tracheal stenosis. Stenosis. When I say single bubble, you say gastric, antral or pyloric, atresia. When I say double bubble, you say duodenal atresia. When I say duodenal atresia, you say Downs. When I say single bubble with distal gas, you say maybe midgut volvulus. When I say non-bilious vomiting, you say hypertrophic pyloric stenosis when I say paradoxal aciduria, you say hypertrophic pyloric stenosis when L say bilious vomiting. In an infant, you say midgut volvulus when I say corkscrew duodenum, you say midgut volvulus when I say reversed SMA and SMV, you say malrotation when I say absent gallbladder, you say biliary atresia when I say triangle cord sign, you say biliary atresia when I say asplenia, you say cyanotic heart disease. 422. When I say infarcted spleen, you say sickle cell when I say gallstones, you say sickle cell when I say short microcolon, you say colonic atresia when I say long microcolon, you say meconium ileus or distal ileal atresia when I say sawtooth colon, you say Hirschsprung when I say calcified mass in the mid-abdomen of a newborn, you say meconium peritonitis when I say meconium ileus equivalent, you say distal intestinal obstruction syndrome, CF. When I say abrupt caliber change of the aorta below the celiac axis, you say hepatic hemangioendothelioma. When I say cystic mass in the liver of a newborn, you say mesenchymal hamartoma. When I say elevated AFP, with mass in the liver of a newborn, you say hepatoblastoma. When I say common bile duct measures more than 1 ohm, you say choldochal cyst. When I say lipoma to pseudohypertrophy of the pancreas, you say CF. When I say unilateral renal agenesis, you say unicornuate uterus. When T say neonatal renal vein thrombosis, you say maternal diabetes. When I say neonatal renal artery thrombosis, you say misplaced umbilical artery catheter. When I say hydro on fetal MRI, you say posterior urethral valve. When I say uricus, you say bladder adenocarcinoma. When I say nephroblastomatosis with necrosis, you say Wilms. When I say solid renal tumor of infancy, you say mesoblastic nephroma. When I say solid renal tumor of childhood, you say Wilms. When I say midline pelvic mass in a female, you say hydrometrocalpo. When I say right-sided varicocele, you say abdominal pathology. When I say blue dot sign, you say torsion of the testicular appendages. When I say hand or foot pain or swelling in an infant, you say sickle cell J with hand-foot syndrome. When I say extratesticular scrotal mass, you say embryonal rhabdomyosarcoma. When I say narrowing of the interpedicular distance, you say achondroplasia. When I say platies pondili, flat vertebral bodies, you say thanatophoric. When I say absent tonsils after 6 months, you say immune deficiency. When I say enlarged tonsils well after childhood, like 12 to 15, you say cancer. Probably lymphatic. When I say mystery liver abscess in kid, you say chronic granulomatous disease. 423. High-yield trivia. Pulmonary interstitial emphysema, PI, put the bad side down. Bronchial foreign body, put the lucency side down. If it stays that way, it's positive. Papillomatosis has a small, 2%, risk of squamous cell CA. Pulmonary sling is the only variant that goes between the esophagus and the trachea. This is associated with trachea stenosis. T-hemic rebound, seen after stress, chemotherapy, can be PET-avid lymphoma, most common mediastinal mass in child, over 10, anterior mediastinal mass with calcification, either treated lymphoma, or thymic lesion. Lymphoma doesn't calcify unless treated. Neuroblastoma is the most common posterior mediastinal mass in child under 2, primary thoracic does better than ABD. Hypertrophic pyloric stenosis, not at birth, not after 3 months, 3 weeks to 3 months is easiest for me to remember. Criteria for HPS, 4 mm and 14 mm, 4 mm single wall, 14 mm length. Annular pancreas presents as duodenal obstruction in children and pancreatitis in adults. Most common cause of bowel obstruction in child over 4 equals appendicitis intussusception, 3 months to 3 years is okay. Earlier or younger. Think lead point gastroschisis, is always on the right side. Omphalocele, has associated anomalies, gastroschisis does not. Physiologic gut hernia normal at 6 to 8 weeks. AFP is elevated with hepatoblastoma. Endothelial growth factor is elevated with hemangioendothelioma. Most common cause of pancreatitis in a kid equals trauma, seatbelt, Weigert-Meyer rule, duplicated ureter on top inserts inferior and medial. Most common tumor of the fetus or infant. Sacrococcygeal teratoma. Most common cause of idiopathic scrotal edema. HSB. Most common cause of acute scrotal pain age 7 to 14, torsion of Testicular appendages bell clapper deformity is the etiology for testicular torsion. SCFE is a Salter-Harris type 1 physiologic periosteitis of the newborn doesn't occur in a newborn, seen around 3 months. Acetabular angle should be 30, and alpha angle should be more than 60. 424. R. Section 2, GI. Problem solving through MRI. Different programs have variable volume with MRI. Some of you will be excellent at it. Some of you will suck at it. An important skill to have is to understand how to problem solve with different sequences. The best way to do this is to have a list of TL bright things, T2 bright things, dark things, and things that restrict diffusion. TL bright. Fat melanin, melanoma, water. T2 bright. Blood, subacute, UD extracellular ethhemoglobin, protein-rich fluid Oslo tumors Ca leification, hyalinized, slow-moving blood laminar necrosis. Be able to move through sequences and problem solve. Restricts diffusion. Stroke hypercellular tumor epidenoid. Abscess, bacterial, acute demyelination. CJD-T2 shine through. Think about a lipoma for example. This will be TL bright, T2 bright, and fat sat out. Another example might be something with layers in it. What can layer? Fat could layer, water could layer, blood could layer, pus could layer. Fat would be bright/bright. Water would be dark on TL, pus would be dark on T2. Blood could do different things depending on its age. Fat would sat out. Pus may restrict diffusion, like a subdural empyema. You get the idea. Run through some scenarios in your mind. The key point is to know your differentials for this. 425. Classic gamesmanship. They could show you a dilated esophagus on CT or barium. Then they show you ground glass in the lung bases, and subpleural sparing if you are lucky. This answer is scleroderma with NSIP. Benign liver masses. Ultrasound CT Mr. Trivia. Hemangioma hyperechoic peripheral nodular discontinuous enhancement. FNH spoke wheel homogeneous arterial enhancement. Hepatic adenoma variable. Hepatic hyperechoic gross fat angiomyolipoma. Location. H. pylori gastritis, usually in antrum. T2 bright rare in cirrhotics. Stealth central scar bright on lesion, so delayed eovist on TL, and a GDEOB T2, DTPA. Fat OCP use can explode containing glycogen, and bleed on in/out storage phase disease. TL/T2 bright unlike renal tuberous AML, 50% sclerosis don't have fat. Zollinger-Ellison ulcerations in the stomach, jejunal ulcer is the buzzword. Duodenal bulb is actually the most common location for ulcers in ZE. Crohn's, uncommon in the stomach, but when it is, it likes the antrum mainatriase, usually in the fundus, classically spares the antrum. Lymphoma, crosses the pylorus, classically described as doing so, although in reality adenocarcinoma does it more. Infections, Giardia duodenum. Strongyloides, duodenum TB, terminal ileum Yersinia, terminal ileum. 426. This vs that, herpes esophagitis equals multiple small ulcers CMV, and AIDS equals solitary large ulcer. This vs that, esophageal cancer, squamous cell equals black guy who drinks and smokes, mid-esophagus adenocarcinoma equals white guy with reflux, history of PPIs, lower esophagus. This vs that, uphill vs downhill varices. Uphill varices caused by portal hypertension, downhill varices caused by SVC obstruction, catheter related. Or tumor related, confined to bottom half of esophagus, confined to top half of esophagus. This vs that, traction vs PU/Zion diverticulum. Traction triangular will empty. Pulsion round will not empty, contain no muscle in their walls. This vs that, esophageal hernias sliding, GE junction above the diaphragm rolling, GE junction below the diaphragm. This vs that, Carney triad vs Carney's complex. Carney's triad Carney's complex extraadrenal pheochromocytoma, cardiac myxoma *, C for complex. Gist skin stuff. Pulmonary chondroma, hamartoma, endocrine stuff. 427. This vs that, benign vs malignant ulcers on barium. Malignant width, depth located within lumen nodular, irregular edges folds adjacent to ulcer and mini, Carmen meniscus sign. This vs that, inguinal hernia. Direct less common medial to inferior epigastric defect in Hesselbach triangle not covered by internal spermatic fascia. This vs that, Crohn's and UC. Crohn's slightly less common in the USA discontinuous, skips, teninal ileum, string sign ileocecal valve stenost. Benign depth, width project behind the expoclede lumen sharp contrafolds radiate to ulcer and mini, Hampton's line. Indirect more common lateral to inferior epigastric failure of processes vaginal is to close covered by internal spinatic fascia. UC slightly more common in the USA continuous rectum. Mesenteric fat increased, creeping fat, lymph nodes are usually enlarged makes fistula. Heacecal valve open perirectal fat increased lymph nodes are not usually enlarged dozen, T usually make fistula. 428. This vs that VO/VU/us. Sigmoid old person, constipated, points to the RUQ. Cecal younger person, mass. Prior surgery, or third trimester pregnancy, points to the LUQ. This vs that, liver nodules. Regenerative dysplastic HCC contains iron contains fat, glycoprotein TL dark, T2 dark TL bright, T2 dark T2 bright does not enhance usually does not enhance does enhance. This vs that, central scars. FNH FL HCC T2 bright T2 dark, usually, enhances on delays does not enhance MAC, S is sulfur colloid avid, sometimes, mass is gallium avid. This vs that, hepatic adenoma vs FNH. Hepatic adenoma FNH usually 8 cm usually 8 cm no bile ducts normal bile ducts no Kupfer cells normal Kupfer cells sulfur colloid cold sulfur colloid hot, sometimes. 429. This vs that, HCC vs fibrolamellar HCC FL HCC cirrhosis no cirrhosis older 50s to 60s, young 30s, rarely calcifies sometimes elevated AFP normal AFP. This vs that, hemochromatosis, primary vs secondary genetic, increased acquired chronic illness, absorption and multiple transfusions liver, pancreas liver, spleen heart, thyroid pituitary. 430. When I say this, you say that. When I say narrowed B ring, you say Shatsky, shit B key ring. When I say esophageal concentric rings, you say eosinophilic esophagitis. When I say shaggy, or plaque-like esophagus, you say candidiasis. When I say looks like candida but an asymptomatic old lady, you say glycogen acanthosis. When I say reticular mucosal pattern, you say Barrett's. When I say high stricture with an associated hiatal hernia, you say Barrett's. When I say abrupt shoulders, you say cancer. When I say Killian dehiscence, you say Zenker diverticulum. When I say transient, fine transverse folds across the esophagus, you say feline esophagus. When I say bird's beak, you say achalasia. When I say solitary esophageal ulcer, you say CMV or AIDS. When I say ulcers at the level of the arch or distal esophagus, you say medication-induced. When I say breast cancer and bowel hamartomas, you say Cowden's. When I say desmoid tumors and bowel polyps, you say Gardner's. When I say brain tumors and bowel polyps, you say Tickets. When I say enlarged left supraclavicular node, you say Fiorco node, GI cancer. When I say crosses the pylorus, you say gastric lymphoma when I say isolated gastric varices, you say splenic vein thrombus when I say multiple gastric ulcers, you say chronic aspirin therapy. When I say multiple duodenal or jejunal ulcers, you say Zollinger-Ellison when I say pancreatitis after Billroth-2, you say afferent loop syndrome, or when I say weight gain years after Roux-en-Y, you say gastrogastrophystula when I say clover-leak sign duodenum, you say healed peptic ulcer. When I say send-like nodules in the jejunum, you say Whipple's when I say send-like nodules in the jejunum and CD4 100, you say my when I say ribbon-like bowel, you say graft vs host when I say ribbon-like jejunum, you say long-standing celiac when I say moulage pattern, you say celiac. When I say fold reversal of jejunum and ileum, you say celiac. When I say cavitary, low-density, lymph nodes, you say celiac. 431. When I say hidebound or stack or coins, you say scleroderma when I say megaduodenurn, you say scleroderma when I say duodenal obstruction, with recent weight loss, you say SMA syndrome when I say cone-shaped cecum, you say amoebiasis when I say lead pipe, you say ulcerative colitis when I say string sign, you say Crohn's when I say massive circumferential thickening, without obstruction, you say lymphoma when I say multiple small bowel target. Signs, you say melanoma when I say obstructing old lady hernia, you say femoral hernia when I say sac of bowel, you say paraduodenal hernia. When I say scalloped appearance of the liver, you say pseudomyxoma peritoneum when I say HCC without cirrhosis, you say hepatitis B when I say capsular retraction, you say cholangiocarcinoma when I say periportal hypoechoic infiltration and AIDS, you say Kaposi's. When I say sparing of the caudate lobe, you say Budd-Chiari. When I say large T2 bright nodes and Budd-Chiari, you say hyperplastic nodules when I say liver high signal in phase, low signal out phase, you say fatty liver when I say liver low signal in phase, and high signal out phase, you say hemochromatosis when I say multifocal intrahepatic and extrahepatic stricture, you say PSC when I say multifocal intrahepatic and extrahepatic strictures and papillary stenosis, you say AIDS cholangiopathy. When I say bile ducts full of stones, you say recurrent pyogenic cholangitis when I say gallbladder comet tail artifact, you say adenomyomatosis when I say lipoma to pseudohypertrophy of the pancreas, you say CF when I say sausage-shaped pancreas, you say autoimmune pancreatitis when I say autoimmune pancreatitis, you say IgG4 when I say IgG4, you say RP fibrosis, sclerosing cholangitis, fibrosing mediastinitis, inflammatory pseudotumor. When I say wide duodenal sweep, you say pancreatic cancer. When I say grandmother pancreatic cyst, you say serous cystadenoma. When I say mother pancreatic cyst, you say mucinous. When I say daughter pancreatic cyst, you say solid pseudopap. 432. High-yield trivia. Most common benign mucosal lesion of the esophagus equals papilloma. Esophageal webs have increased risk for cancer, and Plummer-Vinson syndrome, anemia plus web, dysphagia lusoria, is from compression by a right subclavian artery. Most patients with aberrant rights don't have symptoms. Achalasia has an increased risk of squamous cell cancer, 20 years later. Most common mesenchymal tumor of the GI tract equals GIST. Most common location for GIST equals stomach. Kruck-Enberg tumor equals stomach, GT, met to the ovary menetriase, involves fundus and spares the antrum. The stomach is the most common location for sarcoid. In the GI tract, gastric remnants have an increased risk of cancer years after Billroth. Most common internal hernia. Left-sided paraduodenal. Most common site of peritoneal carcinomatoses equals retrovesical space. An injury to the bare area of the liver can cause a retroperitoneal bleed. Primary sclerosing cholangitis associated with ulcerative colitis. Extrahepatic ducts are normal with primary biliary cirrhosis. Antimitochondrial antibodies positive with primary biliary cirrhosis. Miritzi syndrome. The stone in the cystic duct obstructs the CBD. Miritzi has a 5x increased risk of GB cancer. Dorsal pancreatic agenesis, associated with diabetes and polysplenia. Hereditary and tropical pancreatitis, early age of onset, increased risk of cancer. Felty's syndrome, big spleen, RA, and neutropenia. Splenic artery aneurysm, more common in women, and more likely to rupture in pregnant women. Insulinoma is the most common islet cell tumor. Gastrinoma is the most common islet cell tumor, with men. Ulcerative colitis has an increased risk of colon cancer if it involves colon past the splenic flexure. UC involving the rectum only does not increase risk of CA. 433. Section 3 GU. Gamesmanship, showing persistent nephrograms, either by plain film or CT, is the classic trick for ATN, usually contrast-induced nephropathy. Gamesmanship, LFU or show a unilateral renal agenesis case. Remember the associations with absent ipsilateral epididymis, absent vas deferens, and ipsilateral seminal vesicle cyst in a man. For a woman, think about Mullerian anomalies, unicornuate uterus. Renal cancer syndromes. Subtype syndrome I association clear, F. cell von Hippel-Lindau papillary hereditary papillary renal carcinoma chromophobe Birt-Hogg-Dube medullary sickle cell trait. Renal cyst syndromes. Adcade cysts in liver. VHL cysts in pancreas. Kidneys arc big. Acquired kidneys are small, uremic. Gamesmanship. If they wanted to ask oncocytoma, they can show it 3 ways. 1. On CT solid mass with central scar. 2. On ultrasound spoke wheel vascular pattern. 3. On PET CT it will be hotter than surrounding renal cortex. Gamesmanship. RCC is typically colder than surrounding renal parenchyma on PET, whereas oncocytoma is typically hotter. Gamesmanship. IVPs haven't been used since the 1970s. If you see one, there are a few tricks. The most common is the medial deviation of the ureters, retroperitoneal fibrosis, or the lateral deviation of the ureters, psoas hypertrophy, or lymph nodes. 434. R. When I say this, you say that. When I say bladder stones, you say neurogenic bladder. When I say pine cone appearance, you say neurogenic bladder. When I say urethra cancer, you say squamous cell CA. When I say urethra cancer, prostatic portion, you say transitional cell CA. When I say urethra cancer, in a diverticulum, you say adenocarcinoma. When I say vas deferens calcifications, you say diabetes. When I say calcifications in a fatty renal mass, you say RCC. When I say protrude into the renal pelvis, you say multilocular cystic nephroma. When I say no functional renal tissue, you say multicystic oistoplastic kidney. When I say multicystic oistoplastic kidney, you say contralateral renal issues 50%. When I say emphysema 2 pyelonephritis, you say diabetic. When I say xanthogranulomatous pyelonephritis, you say Stagham stone. When I say papillary necrosis, you say diabetes. When I say shrunken calcified kidney, you say TB. When I say bilateral medulla nephrocalcinosis, you say medullary sponge kidney. When I say big bright kidney with decreased renal function, you say HIV. When I say history of lithotripsy, you say Page kidney. When I say cortical rim sign, you say subacute renal infarct. When I say history of renal biopsy, you say AVF. When I say reverse diastolic flow, you say renal vein thrombosis. When I say sickle cell trait, you say medullary RCC. When I say young adult renal mass plus severe HTN, you say juxtaglomerular cell tumor. When I say squamous cell bladder CA, you say schistosomiasis. When I say entire bladder calcified, you say schistosomiasis. When I say uricus, you say adenocarcinoma of the bladder. When I say long stricture in urethra, you say gonococcal. When I say short stricture in urethra, you say stratal injury. 435. High-yield trivia. Calcifications in a renal CA are associated with an improved survival. RCC bone mets are always lytic. There is an increased risk of malignancy with dialysis. Horseshoe kidneys are more susceptible to trauma. Most common location for TCC is the bladder. Second most common location for TCC is the upper urinary tract. Upper tract TCC in more commonly multifocal, 12%, as opposed to bladder, 4%. Weigert-Meyer rule. Upper pole inserts medial and inferior ectopic ureters are associated with incontinence in women, not men. Leukoplakia is premalignant, malacolakia is not premalignant. Extraperitoneal bladder rupture is more common, and managed medically. Intraperitoneal bladder rupture is less common, and managed surgically. Indenover stones are the only ones not seen on CT. Uric acid stones are not seen on plain film. 436. High-yield trivia. Calcifications in a renal CA are associated with an improved survival. RCC bone mets are always lytic. There is an increased risk of malignancy with dialysis. Horseshoe kidneys are more susceptible to trauma. Most common location for TCC is the bladder. Second most common location for TCC is the upper urinary tract. Upper tract TCC in more commonly multifocal, 12%, as opposed to bladder, 4%. Weigert-Meyer rule. Upper pole inserts medial and inferior ectopic ureters are associated with incontinence in women, not men. Leukoplakia is premalignant, malakoplakia is not premalignant. Extraperitoneal bladder rupture is more common, and managed medically. Intraperitoneal bladder rupture is less common, and managed surgically. Indenover stones are the only ones not seen on CT. Uric acid stones are not seen on plain film. 436. SEC110N4 reproductive. This vs that bicornuate vs septate uterus. You distinguish the two by the apex oftofundal contour. Apex of fundal contour 5 mm above tubal ostia equals septate. Apex of fundal contour 5 mm above tubal ostia equals bicornuate. Other important trivia is septate has established increased 1SR trimester. Trimester loss. Bicornuates have a lot less problems, maybe no increased risk, depends on who you ask. This vs that, Gartner duct cyst vs Bartholin CYSF. The Gartner duct cyst is above the pubic symphysis, Bartholin is below it. This vs that, central gland prostate CA vs BPH. Prostate CA is usually in the peripheral zone, not the central zone. When it is in the central zone it's T2, smudgy, or charcoal. BPH nodules are usually in the central zone, and they have a sharp border. You can draw a line around them with a pencil. This vs that, symmetrical vs asymmetrical, IUGR. Symmetrical is a baby problem. The head is not spared. It's seen early, including the first trimester. Causes include torch, fetal ETOH, and chromosomal abnormalities. Asymmetrical is a placenta problem. The head is spared. It's normal until the third trimester. Causing include maternal hypertension, severe malnutrition, and Ehlers-Danlos. Gamesmanship, the combination of ovarian mass and a thickened endometrium, should make you think granulosa cell tumors, estrogen making. Gamesmanship, seeing fluid in the endometrial canal of a postmenopausal woman should make you think the cervix is obstructed, either by cancer, or more commonly stenosis. Gamesmanship, a met to the vagina in the anterior wall upper 1/3 is always 90%, upper genital tract. Arnet to the vagina in the posterior wall lower 1/3 is always 90% from the GI tract. (430) 437. Gamesmanship, peritoneal inclusion cysts occur after abdominal surgery from adhesions. If they mention in the question stem, history of abdominal surgery, and it's a GYN case, have that on your radar. Gamesmanship, if hyperemesis is in the question stem, think about things that give you an elevated BHCG, like moles and multiple pregnancy, twins. Gamesmanship, if they show you a varicocele, regardless of what side it's on, a right being more suspicious than left, and it's a next step type deal, you probably should look for the abdominal cancer. 438. When I say this, you say that. When I say unicornuate uterus, you say look at the kidneys. When I say T-shaped uterus, you say to related or vaginal clear cell Ca. When I say marked enlargement of the uterus, you say adenomyosis. When I say adenomyosis, you say thickening of the junctional zone, 12 mm. When I say Wolffian duct remnant, you say Gartner duct cyst. When I say theca lutein cysts, you say moles and multiple gestations. When I say theca lutein cysts and pleural effusions, you say hyperstimulation syndrome, patient on fertility meds. When I say low-level internal echoes, you say endometrioma. When I say T2 shortening, you say endometrioma, shading sign. When I say fishnet appearance, you say hemorrhagic cyst. When I say ovarian fibroma and pleural effusion, you say Meigs syndrome. When I say snowstorm uterus, you say complete mole, first trimester. When I say serum PHCG levels that rise in the 8 to 10 weeks following evacuation of molar pregnancy, you say choriocarcinoma. When I say midline cystic structure near the back of the bladder of a man, you say prostatic utricle. When I say lateral cystic structure near the back of the bladder of a man, you say seminal vesicle cyst. When I say isolated orchitis, you say mumps. When I say onion skin appearance, you say epidermoid cyst. When I say multiple hypoechoic masses in the testicle, you say lymphoma. When I say cystic elements and macrocalcifications in the testicle, you say mixed germ cell tumor. When I say homogeneous and microcalcifications, you say seminoma. When I say gynecomastia and testicular tumor, you say Sertoli Leidig. When I say fetal macrosomia, you say maternal diabetes. When I say one artery adjacent to the bladder, you say two-vessel cord. When I say painless vaginal bleeding in the third trimester, you say placenta previa. When I say mom doing cocaine, you say placenta abruption. When I say thinning of the myometrium, with turbulent Doppler, you say placenta creta. When I say mass near the cord insertion, with flow pulsating at the fetal heart rate, you say placenta chorioangioma. When I say cystic mass in the posterior neck, antenatal period, you say cystic hygroma. When I say pleural effusions and ascites on prenatal US, you say hydrops. 439. When I say massively enlarged bilateral kidneys, you say arcade. When I say twin peak sign, you say dichorionic diamniotic. 440. R. High-yield trivia. Endometrial tissue in a rudimentary horn, even one that does not communicate, increases the risk of miscarriage. Arcuate uterus does not have an increased risk of infertility, it's a normal variant. Fibroids with higher T2 signal respond better to UAE hyaline fibroid degeneration, is the most common subtype. Adenomyosis, favors the posterior wall, spares the cervix. Hereditary non-polyposis colon cancer, NHPCC, have a 50x increased risk of endometrial cancer. Tamoxifen increases the risk of endometrial cancer, and endometrial polyp cervical cancer, that has parametrial involvement, 2B, is treated with chemo/radiation. Cervical cancer without parametrial involvement, 2A, is treated with surgery. Vaginal cancer in adults is usually squamous cell. Vaginal rhabdomyosarcoma occurs in children. Teenagers. Premenopausal ovaries can be hot on PET depending on the phase of cycle. Postmenopausal ovaries should never be hot on PET. Transformation subtypes, endometrioma equals clear cell, dermoid equals squamous. Postpartum fever can be from ovarian vein thrombophlebitis. Fractured penis equals rupture of the corpus cavamosum, and the surrounding tunica albuginea. Prostate cancer is most commonly in the peripheral zone. ADC dark BPH nodules are in the central zone. Hypospadias is the most common association with prostatic utricle. Seminal vesicle cysts are associated with renal agenesis, and ectopic ureters. Cryptorchidism increases the risk of cancer in both testicles and is not reduced by orchiopexy. Immunosuppressed patients can get testicular lymphoma, hiding behind blood testes barrier. Most common cause of correctable infertility in a man is a varicocele. Undescended testicles are more common in premature kids. Membranes disrupted before I0 weeks, increased risk for amniotic bands. The earliest visualization of the embryo is the double Bleb sign. Hematoma greater than 2/3 the circumference of the chorion has a 2x increased risk of abortion. Biparietal diameter, recorded at the level of the thalamus from the outermost edge of the near skull to the inner table of the far skull. Abdominal circumference, does not include the subcutaneous soft tissues. 441. Abdominal circumference is recorded at the level of the junction of the umbilical vein and left portal vein. Abdominal circumference is the parameter classically involved with asymmetric IUGR. Femur length does not include the epiphysis. Umbilical artery systolic I-diastolic ratio should not exceed 3 at 34 weeks. Makes you think preeclampsia and IUGR. A full bladder can mimic a placenta previa. High-yield trivia. Endometrial tissue in a rudimentary horn, even one that does not communicate, increases the risk of miscarriage. Arcuate uterus does not have an increased risk of infertility, it's a normal variant. Fibroids with higher T2 signal respond better to UAE hyaline fibroid degeneration, is the most common subtype. Adenomyosis, favors the posterior wall, spares the cervix. Hereditary non-polyposis colon cancer, NHPCC, have a 30-50x increased risk of endometrial cancer. Tamoxifen increases the risk of endometrial cancer, and endometrial polyp cervical cancer that has parametrial involvement, 2b, is treated with chemo/radiation. Cervical cancer without parametrial involvement, 2a, is treated with surgery. Vaginal cancer in adults is usually squamous cell. Vaginal rhabdomyosarcoma occurs in children. Teenagers. Premenopausal ovaries can be hot on PET depending on the phase of cycle. Postmenopausal ovaries should never be hot on PET. Transformation subtypes, endometrioma equals clear cell, dermoid equals squamous. Postpartum fever can be from ovarian vein thrombophlebitis. Fractured penis equals rupture of the corpus cavamosum, and the surrounding tunica albuginea. Prostate cancer is most commonly in the peripheral zone. ADC dark BPH nodules are in the central zone. Hypospadias is the most common association with prostatic utricle. Seminal vesicle cysts are associated with renal agenesis, and ectopic ureters. Cryptorchidism increases the risk of cancer in both testicles and is not reduced by orchiopexy. Immunosuppressed patients can get testicular lymphoma, hiding behind blood testes barrier. Most common cause of correctable infertility in a man is a varicocele. Undescended testicles are more common in premature kids. Membranes disrupted before I0 weeks, increased risk for amniotic bands. The earliest visualization of the embryo is the double Bleb sign. Hematoma greater than 2/3 the circumference of the chorion has a 2x increased risk of abortion. Biparietal diameter, recorded at the level of the thalamus from the outermost edge of the near skull to the inner table of the far skull. Abdominal circumference, does not include the subcutaneous soft tissues. 441. Abdominal circumference is recorded at the level of the junction of the umbilical vein and left portal vein. Abdominal circumference is the parameter classically involved with asymmetric IUGR. Femur length does not include the epiphysis. Umbilical artery systolic I-diastolic ratio should not exceed 3 at 34 weeks. Makes you think preeclampsia and IUGR. A full bladder can mimic a placenta previa. Nuchal lucency is measured between 9 to 12 weeks and should be 3 mm. More than 3 mm is associated with Downs. Lemon sign will disappear after 24 weeks. Aqueductal stenosis is the most common cause of non-communicating hydrocephalus in a neonate. 442. SECT10NS chest. Gamesmanship AI.DS. Lung cysts equals lip. Lip is AIDS defining in a pediatric patient. Lung cysts plus ground glass plus pneumothorax equals PCP. Hypervascular nodes equals Castleman's or Kaposi. Most common airspace opacity equals strep pneumonia. If they show you a CT with ground glass equals PCP. Flame-shaped perihilar opacity equals Kaposi. Sarcoma persistent opacities equals lymphoma. F infections in AIDS by CD4II. 200I bacterial infections, TB-II, 200I PCP, atypical mycobacterial. 00 ICMV Diesminald ung, L mycobactal. II. 200I bacterial infections, TB-II, 200I PCP, atypical mycobacterial. Infections, TB-II, 200I PCP, atypical mycobacterial. 00 ICMV Diesminald ung, L mycobactal L, 1 dash 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 a dash underscore 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 L. Dash a dash a dash a dash a dash a dash a dash. Dash a dash a dash a dash dash a dash. Dash a dash a dash dash a dash 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 a dash a dash a dash 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 a dash 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 a dash dash a dash dash a gamesman's low tip, mesothelioma. One way to show this is the frozen hemithorax, which is a lack of contralateral mediastinal, dash dash, shift in association with massive pleural effusion. It's due to encasement of the lung and fissures by cancer. Gamesmanship, collagen vascular tricks. RA in the shoulders on frontal CXR equals lower lobe ULP pattern ankylosing spondylitis, on lateral CXR equals upper lobe fibrobullous disease dilated esophagus, on CT equals scleroderma, with NSCP lungs. Gamesmanship, pulmonary edema. After the placement of a chest tube, re-expansion edema, after using a bunch of crack or heroin, drug-induced edema, after a head injury, neurogenic edema, after lung transplant, reperfusion edema related to ischemia/reperfusion, peak day 4. 443. Gamesmanship, upper lobes vs lower lobes. It's useful to have a list of what is upper lobe predominant and what is lower lobe predominant. The easiest way to ask a question would be which of the follow is not upper lobe, or which of the following is upper lobe. Upper lobe predominant, lower lobe predominant. Most inhaled stuff, not asbestosis. Asbestosis, coal workers, and silicosis. This includes progressive massive fibrosis. CF primary ciliary dyskinesia, RBILD. Most interstitial lung diseases, UIP, NSIP, DIP, centrilobular emphysema, panlobular emphysema, alpha-1, ankylosing spondylitis, rheumatoid lung sarcoid scleroderma, associated with NSIP. This vs that, pulmonary vs mediastinal origin. Mediastinal origin will make obtuse margin with lung. Pulmonary origin will make acute margin with lung. This vs that, ground glass nodule, on PET hot GGO equals infection, cold GGO equals cancer. Cancer, BAC, gamesmanship, collapse. Always be on the lookout for collapse. Anytime you see anything that could be collapse, at least entertain the idea. Post-intubation think collapse, placement of central line think collapse, ICU patient with no other details think collapse, mucus plugging, outpatient with no history think collapse, cancer. 444. R. When I say this, you say that. When I say obliteration of Rader's triangle, you say aberrant right subclavian. When I say flat waist sign, you say left lower lobe collapse. When I say terrorist and mediastinal widening, you say anthrax. When I say bulging fissure, you say Klebsiella. When I say dental procedure gone bad, now with jaw osteo and pneumonia, you say actinomycosis. When I say culture negative pleural effusion, 3 months later with airspace opacity, you say TB. When I say hot tub, you say hypersensitivity pneumonitis. When I say halo sign, you say fungal pneumonia, invasive aspergillus. When I say reverse halo or atoll sign, you say COP. When I say finger and glove, you say ABPA. When I say ABPA, you say asthma. When I say septic emboli and jugular vein thrombus, you say Lemire. When I say Lemire, you say Fusobacterium necrophorum. When I say paraneoplastic syndromes with SIAD, you say small cell lung CA. When I say paraneoplastic syndromes with PTH, you say squamous cell CA. When I say small cell lung CA and proximal weakness, you say Lambert-Eaton. When I say cavity fills with air, post-pneumonectomy, you say bronchopleural fistula. When I say malignant bronchial tumor, you say carcinoid. When I say malignant tracheal tumor, you say adenoid cystic. When I say AIDS patient with lung nodules, pleural effusion, and lymphadenopathy, you say lymphoma. When I say gallium negative, you say Kaposi. When I say thallium negative, you say PCP. When I say macroscopic fat and popcorn calcifications, you say hamartoma. When I say bizarre-shaped cysts, you say LCH. When I say lung cysts in a TS patient, you say LAM. When I say panlobular emphysema, not alpha-1, you say Ritalin lung. When I say honeycombing, you say UIP. When I say the histology was heterogeneous, you say UIP. When I say ground glass with subpleural sparing, you say NSIP. When I say UIP lungs and parietal pleural thickening, you say asbestosis. When I say cavitation in the setting of silicosis, you say TB. When I say air trapping seen 6 months after lung transplant, you say chronic rejection I bronchiolitis obliterans syndrome. When I say crazy paving, you say PAP. When I say history of constipation, you say lipoid pneumonia, inferring mineral oil use aspiration. When I say UIP plus air trapping, you say chronic hypersensitivity pneumonitis. When I say dilated esophagus plus ILD equals scleroderma with NSIP. 445. When I say shortness of breath when sitting up, you say hepatopulmonary syndrome. When I say episodic hypoglycemia, you say solitary fibrous tumor of the pleura. When I say pulmonary HTN with normal wedge pressure, you say pulmonary veno-occlusive disease. When I say yellow nails, you say edema and chylous pleural effusions, yellow nail syndrome. When I say persistent fluid collection after pleural drain/tube placement, you say extrapleural hematoma. When I say displaced extrapleural fat, you say extrapleural hematoma. When I say massive air leak, in the setting of trauma, you say bronchial or tracheal Woolgery. When I say hot of PET, around the periphery, you say pulmonary infarct. When I say multilobar collapse, you say sarcoid. When I say classic bronchial infection, you say TB. When I say panbronchiolitis, you say tree in bud, not centrilobular or random nodules. When I say bronchuria, you say mucinous BAC. 446. High-yield trivia. The tricuspid valve is the most anterior. The pulmonic valve is the most superior. There are 10 lung segments on the right, and 8 lung segments on the left. If it goes above the clavicles, it's in the posterior mediastinum, cervicothoracic sign. Azygous lobe has 4 layers of pleura. Most common pulmonary vein variant is a separate vein draining the right middle lobe. Most common cause of pneumonia in AIDS patient is strep pneumonia. Most common opportunistic infection in AIDS equals PCP. Aspergilloma is seen in a normal immune patient. Invasive aspergillus is seen in an immune-compromised patient. Fleischner Society recommendations do not apply to patients with known cancers. Eccentric calcifications in a solitary pulmonary nodule pattern is considered the most suspicious. A part solid nodule with a ground glass component is the most suspicious morphology. You can have most common lung CA to present as solitary nodule. Stage 3B lung CA is unresectable, contralateral nodal involvement, ipsilateral or contralateral scalene or supraclavicular nodal involvement, tumor in different lobes. The most common cause of unilateral lymphangitic carcinomatoses is bronchogenic carcinoma, lung cancer invading the lymphatics. There is a 20-year latency between initial exposure and development of lung cancer or pleural mesothelioma. Pleural effusion is the earliest and most common finding with asbestosis exposure. Silicosis actually raises your risk of TB by about 3-fold. Nitrogen dioxide exposure is Silo-Filler's disease, gives you a pulmonary edema pattern. Reticular pattern in the posterior costophrenic angle is supposedly the first finding of all P on CXR. Sarcoidosis is the most common recurrent primary disease. After lung transplant, pleural plaque of asbestosis typically spares the costophrenic angles. Pleural effusion is the most common manifestation of METs to the pleura. There is an association with mature teratomas and Klinefelter syndrome. Injury close to the carina is going to cause a neuronomodiastinum rather than a pneumothorax. MRI is superior for assessing superior sulcus tumors because you need to look at the brachial plexus. Leiomyoma is the most common benign esophageal tumor, most common in the distal third. Esophageal leiomyomatoses may be associated with Allport syndrome. Bronchial I tracheal injury must be evaluated with bronchoscopy. 447. If you say COP, also say eosinophilic pneumonia. If you say BAC, also say lymphoma. Bronchial atresia is classically in the LUL pericardia. Cysts must be simple. Bronchogenic cysts don't have to be simple. PAP follows a rule of L/3S post-treatment. 1/3 gets better, 1/3 doesn't, 1/3 progresses to fibrosis. Dysphagia lusoria presents later in life as atherosclerosis develops. Carcinoid is cold on PET. Wegener's is now called granulomatosis with polyangiitis. Wegener was a Nazi. Apparently he was not just a Nazi, he was a Nazi before it was fashionable. Plus, I heard he was a real asshole, and a bad tipper, which is unforgivable. 448. Section 6 Cardiac. Gamesmanship, congenital. Carcinoid is cold on pet Wagoners is now. Section 6 Cardiac. Gamesmanship, congenital heart disease. My idea is that you can only write 3 kinds of multiple choice questions regarding congenital heart disease. 1. Ant Mini. 2. Differential with crappy distractions. And 3. Association/trivia. Situation 1. The Ant Mini. There are a few congenital heart cases that are straight up Ant Minis. The usual characters that most third-year medical students memorize are fair game. Scimitar sword, tapper with hypoplasia. 449. Right. 1. What side is the arch on? TOF or truncus? Cyanotic. Asterisk. They have to tell you this if they want a single answer. Not cyanotic. Left. Massive. _. 2. Heart size. 3. Pulmonary blood flow. 0. Dot. The next thing to ask is what side the arch is on. If you see it on the left, it's not helpful. If you see it on the right, think TOF and truncus. Example, patient X is a newborn cyanotic with CXR shown. What is the most likely DX? AASD, BVSD are C tricuspid atresia DTOF. So ASD and VSD are out because they are not cyanotic. You notice the right arch, so you call it TOF. Example, patient X is a newborn cyanotic with CXR shown. What is the most likely DX? AASD, BVSD, C truncus DTOF. Now if they would give you the same picture but add the choice truncus, then you would have to look at the lungs. Vasculature increased with truncus, and normal I decreased with TOF. I have to show you a normal left arch. The first thing I like to do is ask is the heart is massively enlarged. This gives you a differential of cardiac causes and non-cardiac causes. Cardiac, Epstein's or pulmonary atresia without VSD. Non-cardiac, high-flow states like vein of Galen. Malformation and hepatic hemangioendothelioma. Obviously they have to show you a liver or brain next with these two. 451. Lastly, the difference between increased and normal/decreased pulmonary vasculature can help eliminate distractors. I want to stress not trying to tell normal and decreased apart on crappy monitors. It's hard enough on a real viewing monitor. The distinction is not necessary for multiple choice. Tapper, especially type 3 supra, DT ranspo. Sit phone truncus, look for right arch, tingle ventricle. TOF Epstein's tricuspid atresia. Example, patient with cyanotic heart disease, with CXR shown. What is the most likely DX? AASD BVSCC, tricuspid atresia D tapper. ASD and VSD are not cyanotic. Tricuspid atresia has decreased pulmonary vasculature, the CXR shows increased. That leaves tapper. 452. Gamesmanship, signs of left atrial enlargement. 1. Double density, superimposed over contour of the right heart. 2. Splaying of the carina, angle over 90 degrees. 3. Posterior displacement of the heart, seen on the lateral CXR. Gamesmanship, which MRI sequence is best? L. Pathology, which sequence, S, most useful? I. Cardiac myxoma, I. Low TL, high T2, high myxoid content. I. Acute vs chronic MI, look at T2, bright on acute, dark on chronic, fibrous scar. I. J. Arrhythmogenic right ventricular TL, bright eye dysplasia, ARVD. I. LM microvascular obstruction, first pass perfusion, 25 seconds post-GAD, Wolfart delayed enhancement, L0 to 12 mins post-GAD, dash. This VS that, constrictive VS restrictive cardiomyopathy, pericardium is usually thickened in constrictive diastolic septa bounds is seen in constrictive, sigmoidization of the septum. This vs that, true vs false ventricular aneurysm. True, mouth is wider than body. Myocardium is intact. Usually anterior lateral wall. False, mouth is narrow compared to body. Myocardium is not intact. Pericardia, adhesions contain rupture. Usually posterior lateral wall. Higher risk of rupture. This vs that, valve anatomy. 1 aortic valve, right, left and posterior cusps. Pulmonic valve, right, left and anterior cusps. LR, 453. This vs that, stunned vs hibernating myocardium. Stunned myocardium. After an acute injury, ischemia, or reperfusion injury, dysfunction of myocardium persists, even after restoration of blood flow, can last days to weeks. A perfusion study will be normal, but the contractility is crap. Hibernating myocardium. This is a more chronic process, and the result of severe CAD causing chronic hypoperfusion. You will have areas of decreased perfusion, and decreased contractility even when resting. Don't get it twisted, this is not an infarct. On a FDG PET, this tissue will take up tracer more intensely than normal myocardium, and will also demonstrate redistribution of thallium. This is reversible with revascularization. Scar, this is dead myocardium. It will not squeeze normally, so you'll have abnormal wall motion. It's not a zombie. It will not come back to life with revascularization. Stunned hibernating infarct. I scar, I. Wall motion abnormal. Wall motion abnormal. Normal perfusion, thallium abnormal. Fixed perfusion or sestamibi, will redistribute with delayed thallium, and will take up fog, associated with acute ML associated with chronic high grade CAD. This vs that, left atrial myxoma vs clot. The myxoma will enhance. TH is vs that. That, vegetations vs fibroelastoma. Fibroelastoma. Wall motion abnormal. Abnormal fixed perfusion. Will not redistribute with delayed thallium. Will not take up fog. Associated the chronic prior ML. You tell the difference by looking for valvular damage seen with vegetations. Contrast enhancement is not very reliable because of how small these things are. 454. When I say this, you say that. When I say Say Alcapa, you say Steele syndrome when I say supravalvular aortic stenosis, you say Williams syndrome when I say bicuspid aortic valve and coarctation, you say Turner syndrome when I say isolated right upper lobe edema, you say mitral regurgitation when I say peripheral pulmonary stenosis, you say Alagille syndrome when I say box-shaped heart, you say Epstein's when I say right arch with mirror branching, you say congenital heart. When I say hand/thumb defects and ASD, you say Holt Oram when I say ostium prim.um ASD, or endocardial cushion defect, you say Downs when I say right-sided PAPR, you say sinus venosus ASD when I say calcification in the left atrium wall, you say rheumatic heart disease when I say difficult to suppress myocardium, you say amyloid when I say blood pool suppression on delayed enhancement, you say amyloid when I say septa. Bounce, you say constrictive pericarditis. When I say ventricular interdependence, you say constrictive pericarditis. When I say focal thickening of the septum, but not hypertrophic cardiomyopathy, you say sarcoid. When I say ballooning of the left ventricular apex, you say Takotsubo. When I say fat in the wall of a dilated right ventricle, you say arrhythmogenic right ventricular cardiomyopathy, ARVC. When I say kid with dilated heart and mid-wall enhancement, you say muscular dystrophy. When I say cardiac rhabdomyoma, you say tuberous sclerosis. When I say bilateral atrial T thrombus, you say eosinophilic cardiomyopathy. When I say diffuse Lee subendocardial enhancement, not restricted to a vascular distribution, you say cardiac amyloid. When I say Glenn P. Rostor, you say acquired pulmonary AVMs. When I say pulmonary vein stenosis, you say ablation for AFib. When I say multiple cardiac myxomas, you say Carney's complex. 455. High-yield trivia. The right atrium is defined by the IVC. The right ventricle is defined by the moderator band. The tricuspid papillary muscles insert on the septum, mitral ones do not. Lipoma-2 hypertrophy of the interatrial septum can be PET avid, it's brown fat. LAD gives off diagonals RCA gives off acute marginals LCX gives off obtuse marginals RCA perfuses SA and AV nodes. Most of the time, dominance is decided by which vessel lives off the posterior descending. It's the right 85% LCA from the right coronary cusp. Always gets repaired RCA from the left coronary cusp. Reparative symptoms most common location of myocardial bridging is in the mid portion of the LAD. Coronary artery aneurysm, most common cause in adult equals atherosclerosis. Coronary artery aneurysm, most common cause in child equals Kawasaki. Left-sided SVC empties into the coronary sinus. Rheumatic heart disease is the most common cause of mitral stenosis. Pulmonary arterial hypertension is the most common cause of tricuspid atresia. Double most common vascular ring is the double aortic arch. Most common congenital heart disease is a VSD. Most common ASD is the secundum infracardiac tapper, classically shown with pulmonary edema in a newborn. L transposition type is congenitally corrected. They are L ucky. D transposition type is doomed. Truncus is associated with catch-22 de George. Rib notching from coarctation spares the first and second ribs. Infarct with 50% involvement is unlikely to recover function. Microvascular obstruction is no T seen in chronic infarct. Amyloid is the most common cause of restricted cardiomyopathy. Primary amyloid can be seen in multiple myeloma. Most common neoplasm to involve the cardiac valves equals fibroelastoma. Most commonly the congenital absence of the pericardium is partial and involves the pericardium over the left atrium and adjacent pulmonary artery. The left atrial appendage is the most at risk to become strangulated. Glenn shunt, SVC to pulmonary artery, vein to artery. Blalock-Taussig shunt, subclavian artery to pulmonary artery, artery. Ross procedure, replaces aortic valve with pulmonic, and pulmonic with a graft, done for kids. 456. R. Aliasing is common with cardiac MRI. You can fix it by 1. Opening your FOV, 2. Oversampling the frequency encoding direction, or 3. Switching phase and frequency encoding directions. Giant coronary artery aneurysms, 8 mm, don't regress, and are associated with MLS. Whitberry-Berry, thiamine def, can cause a dilated cardiomyopathy. Most common primary cardiac tumor in children equals rhabdomyoma. 2 degree D. Most common primary cardiac tumor in children equals fibroma. Most common complication of MI is myocardial remodeling. Unroofed coronary sinus is associated with persistent left SVC. Most Section 7 Vascular. Gamesmanship. Thoracic angiogram. If you see an angiogram through the great vessels and aorta, think about TOS, Takayasu, and giant cell. The locations are classic and helpful. Having said that, remember Takayasu is going to be a young person, probably Asian female, and giant cell is going to be an old person, age trumps location. If they show you TOS, they will show the arms up and down, dead giveaway. If the history is trauma, don't forget to look at the great vessels, not just the aorta. Gamesmanship, aortic dissection on angiogram. Our Takayasu can be shown as opacification of abdominal aortic branch vessels during aortography, catheter placed in the aortic true lumen, with the branch vessels, celiac axis, superior mesenteric artery, and renal arteries, arising out of nowhere. They appear to be floating, with little or no antegrade opacification of the aortic true lumen. This is the so-called floating viscera sign. Gamesmanship, collateral filling. If you inject the SMA and the celiac branches fill, infers a tight stenosis at the celiac origin. If you inject the celiac and the SMA branches fill, infers a tight stenosis at the SMA origin. Gamesmanship, hand angiograms. Pathology, it's going to be either Burgers of Hypothenar-Hammer syndrome, HHS. Ask yourself, is the ulnar artery involved? If yes, go with the HHS. If the ulnar nerve looks okay, but the fingers are out, go with Burgers. Be careful because the fingers can be out with HHS as well, distal emboli. Pseudoaneurysm off the ulnar artery is a slam dunk for HHS. 458. Section 7 Vascular. Gamesmanship, thoracic angiogram. If you see an angiogram through the great vessels and aorta, think about TOS, Takayasu, and giant cell. The locations are classic and helpful. Having said that, remember Takayasu is going to be a young person, probably Asian female, and giant cell is going to be an old person, age trumps location. If they show you TOS, they will show the arms up and down, dead giveaway. If the history is trauma, don't forget to look at the great vessels, not just the aorta. Gamesmanship, aortic dissection on angiogram. Our Takayasu can be shown as opacification of abdominal aortic branch vessels during aortography, catheter placed in the aortic true lumen, with the branch vessels, celiac axis, superior mesenteric artery, and renal arteries, arising out of nowhere. They appear to be floating, with little or no antegrade opacification of the aortic true lumen. This is the so-called floating viscera sign. Gamesmanship, collateral filling. If you inject the SMA and the celiac branches fill, infers a tight stenosis at the celiac origin. If you inject the celiac and the SMA branches fill, infers a tight stenosis at the SMA origin. Gamesmanship, hand angiograms. Pathology, it's going to be either Burgers of Hypothenar-Hammer syndrome, HHS. Ask yourself, is the ulnar artery involved? Involved. If yes, go with the HHS. If the ulnar nerve looks okay, but the fingers are out, go with Burgers. Be careful because the fingers can be out with HHS as well, distal emboli. Pseudoaneurysm off the ulnar artery is a slam dunk for HHS. 458. Gamesmanship, renal artery angiogram. Osteal narrowing, think atherosclerosis, treat with balloon, and stent beating mid-vessel, think FMD, treat with balloon only. Gamesmanship, kidney angiogram. First question should always be, LS there an RCC or AML? Second question should be, is there penny-speed kidney? A bunch of little aneurysms. Gamesmanship, Kawasaki. Two classic ways to show this: 1. CT showing a coronary artery aneurysm, the obvious one; 2. CA-jaceified coronary artery aneurysm shown on a CXR. This was an old oral board's favorite. This vs that, aortic coarctation. Infantile, preductal, these guys can have pulmonary edema. More typically a long segment. Blood supply to the descending aorta is via the PDA. Adult, ductal, not symptomatic until later in childhood. Often presents with differential arm/leg blood pressures. More typically a short segment. This vs that, external vs internal carotid. L-I internal carotid, external carotid I, low resistance I, high resistance. Low systolic velocity, high systolic velocity I, diastolic velocity docs. Not return to baseline, diastolic velocity approaches zero baseline I, continuous color flow is seen throughout the color flow is intermittent during the cardiac cycle. Also you can, 1. Look for branches of the external carotid, or 2. Use a temporal tap to see ripples in the ECA spectrum. 459. The surgically created AV fistula has superior longevity. A fistula typically needs 3 to 4 months to mature, vein to enlarge enough for dialysis. A synthetic graft will be ready for use in 2 weeks. A synthetic graft is usually easier to declot. The clot is usually confined to the synthetic graft. Gamesmanship tips. There are several sneaky things that can be shown related to tips. C02 run during hepatic vein wedge, blowing the liver dome off, because the injection was too strong. Anytime you see a C02 run over the liver, think about this. Tips placed into the hepatic artery, not portal vein. Remember to confirm that you are in the right structure, pay attention to the anatomy. They could tell you the portal systemic gradient was normal, 3 to 6. Remember that tips treats portal hypertension. Don't do AA tips on someone who does not have portal HTN. Filter placement. Indication filter placement rationale: pregnancy suprarenal to avoid compression, clot in the renals or suprarenal, get above the clot gonadals either bilateral iliac or duplicated IVC suprarenal, above the GOTA, block them both bifurcation. Circumaortic left renal below the lowest renal risk of clot by passing filter via the renals. 464. Embolization next steps: autologous blood clot equals post-traumatic high-flow priapism varicocele, spermatic vein, equals coils uterine fibroid embolization, bilateral uterine artery, equals PVA, or microspheres 5001000 RN diffuse splenic trauma, proximal embolization, equals amplots, a plug in the splenic artery proximal to the short gastric arteries. Pulmonary AVM equals coils hemoptysis, bronchial artery embolization, equals PVA particles, 325 m. Hypervascular spinal tumor equals onyx, total renal embolization equals absolute ethanol partial, or selective renal embolization equals glue, bucrolated iodized oil, segmental renal artery aneurysm equals coils, main renal artery aneurysm equals covered stent, or coils after bare metal stent, peripartum hemorrhage equals gel foam, upper GI bleed equals endoscopy first. If that fail, then in most cases coils, lower GI bleed equals usually microcoils. 465. The surgically created AV fistula has superior longevity. A fistula typically needs 3 to 4 months to mature, vein to enlarge enough for dialysis. A synthetic graft will be ready for use in 2 weeks. A synthetic graft is usually easier to declot. The clot is usually confined to the synthetic graft. Gamesmanship tips. There are several sneaky things that can be shown related to tips. C02 run during hepatic vein wedge, blowing the liver dome off, because the injection was too strong. Anytime you see a C02 run over the liver, think about this. Tips placed into the hepatic artery, not portal vein. Remember to confirm that you are in the right structure, pay attention to the anatomy. They could tell you the portal systemic gradient was normal, 3 to 6. Remember that tips treats portal hypertension. Don't do AA tips on someone who does not have portal HTN. Filter placement. Indication filter placement rationale: pregnancy suprarenal to avoid compression, clot in the renals or suprarenal, get above the clot gonadals either bilateral iliac or duplicated IVC suprarenal, above the GOTA, block them both bifurcation. Circumaortic left renal below the lowest renal risk of clot by passing filter via the renals. 464. Embolization next steps: autologous blood clot equals post-traumatic high-flow priapism varicocele, spermatic vein, equals coils uterine fibroid embolization, bilateral uterine artery, equals PVA, or microspheres 5001000 RN diffuse splenic trauma, proximal embolization, equals amplots, a plug in the splenic artery proximal to the short gastric arteries. Pulmonary AVM equals coils hemoptysis, bronchial artery embolization, equals PVA particles, 325 m. Hypervascular spinal tumor equals onyx, total renal embolization equals absolute ethanol partial, or selective renal embolization equals glue, bucrolated iodized oil, segmental renal artery aneurysm equals coils, main renal artery aneurysm equals covered stent, or coils after bare metal stent, peripartum hemorrhage equals gel foam, upper GI bleed equals endoscopy first. If that fail, then in most cases coils, lower GI bleed equals usually microcoils. 465. Abscess trivia summary: size, 6 to 8 f for clear fluid, 8 to 10 f for thin pus, 10 to 12 f for thick pus, 1 to f plus for collections with debris, or in collections that smell like a zombie farted. Up the size if the tube keeps clogging. General ideas for choosing the correct route: 1. All things equal, pick the shortest route. 2. Avoid bowel. Bowel, solid organs, blood vessels, inferior epigastrics are classic. Nerves. 3. Try not to contaminate sterile areas. 4. Choose the most dependent position possible, usually posterior or lateral, to to facilitate drainage. Transgluteal equals stay medial. Presarcal equals consider transrectal. Recto-uterine pouch collection equals consider transvaginal, over the age of 14. Removing the tube, remove the catheter when 1. Drainage is less than 1 OCC a day, 2. The collection is resolved by imaging, CT, ultrasound, etc., and 3. There is no fistula. 466. When I say this, you say that. When I say foresee greater than 28 millimeters, you say mega cava. When I say mega cava, you say bird's next filter. When I say hairpin turn, during bronchial angiography, you say anterior medullary, spinal cord, artery. When I say fever, WBC, nausea, and vomiting after uterine artery embolization, you say post-embolization syndrome, obviously could also be infection. When I say most medial vessel in the leg, you say posterior tibial. When I say the source of 85% of upper GI bleeds, you say left gastric. When I say the source of bleeding from a duodenal ulcer, you say GDA. When I say pulmonary AVM, you say HHT. When I say most feared complication of bronchial artery embolization, you say spinal cord infarct. When I say high risk of bleeding for liver transplant, you say transjugular approach. When I say most feared complication of brachia arterial access, you say compartment syndrome. When I say cold painful fingers during dialysis, you say Steele syndrome. When I say ulcer on medial ankle, you say venous stasis. When I say ulcer on dorsum of foot, you say ischemia, or infected ulcer. When I say ulcer on plantar surface of foot, you say neutropenic ulcer. 467. High yield trivia. 1 8G needle will accept a 0.038-inch guide wire, 1 9G needle will allow a 0.035-inch guide wire. Notice that 0.039, 0.035, 0.018 wires are in inches. 3 French equals 1 millimeter. French size is the outside of a catheter, and the inside of a sheath. End hole only catheters equals hand injection only. Side hole plus end hole equals power injection. Okay. Coils not okay. Double flush technique equals for neuro IR. No bubbles ever. Significant lesion equals a systolic pressure gradient, 10 mmHg at rest. Things to not stick a drain in, tumors, acute hematoma, and those associated with acute bowel rupture and peritonitis. Renal artery stenting for renal failure tends to not work if the CR is 3. Persistent sciatic artery is prone to aneurysm even if the cholecystostomy tube instantly resolves all symptoms. You need to leave the tube in for 2 to 6 weeks until the tract matures, otherwise you are going to get a bile leak. MELD scores greater than 24 are at risk of early death with TIPS. The target gradient post-TIPS for esophageal bleeding is between 9 and 11. Absolute contraindication for TIPS, heart failure, severe hepatic failure. Most common side effect of BRTO is gross hematuria. Sensitivity equals GI bleed. Scan equals 0.1 ml/min. Angiography equals 1.0 ml/min for GI bleed. After performing an embolization of the GDA, for duodenal ulcer, you need to do a run of the SMA to look at the inferior pancreaticoduodenal. Most common cause of lower GI bleed is diverticulosis. TACE will prolong survival better than systemic chemotase. Portal vein thrombosis is considered a contraindication, sometimes, because of the risk of infracting the liver. Go above the rib for thora. Left bundle branch block needs a pacer before a thoracic angiogram. Never inject contrast through a Swan-Ganz catheter for a thoracic angiogram. You treat pulmonary AVMs at 3 mm. Hemoptysis, active extravasation, is not typically seen with the active bleed. UAE, gonadotropin-releasing medications, often prescribed for fibroids, should be stopped for 3 months prior to the case. The general rule for transgluteal is to avoid the sciatic nerves and gluteal arteries by access through the sarcospinous ligament medially, close to the sacrum, inferior to the piriformis. When to pull an abscess catheter, as a general rule, when the patient is better, no fever, WBC normal, and output is 20 centimeters cubed over 24 hours. If the thyroid biopsy is non-diagnostic, you have to wait 3 months before you rebiopsy. 468. Posterior lateral approach is the move for percutaneous nephrostomy. You can typically pull a sheath with an ACT, 150 to 180 artery calcifications, common in diabetics, make compression difficult, and can lead to a false elevation of the ABI. Type 2 endoleaks are the most common. Type 1 and Type 3 endoleaks are high pressure and need fixed stat circumaortic left renal vein. The anterior one is superior, the posterior one is inferior, and the filter should be below the lowest one. Risk of DVT is increased with IVC filters. Filter with clot, 1 centimeter cubed of clot equals filter stays in. Acute Budd-Chiari with Fouget-Minant liver failure equals needs a TIPS. Pseudoaneurysm of the pancreaticoduodenal artery equals sandwich technique. Distal and proximal segments of the artery feeding off the artery must be embolized. Median arcuate ligament syndrome. First line is surgical release of the ligament. Massive hemoptysis equals bronchial artery. Particles bigger than 325 micrometers. Acalculous cholecystitis equals percutaneous cholecystostomy. Hepatic encephalopathy after TIPS equals U. Can either 1. Place a new covered stent constricted R in the middle by a loop of suture, deployed in the pre-existing TIPS. 2. Place 2 new stents, parallel to each other, 1 covered self-expandable, 1 uncovered balloon expandable. Recurrent variceal bleeding after placement of a constricted stent, balloon dilation of the constricted stent. Appendiceal abscess, drain placement asterisk. Just remember that a drain should be used for a mature, walled-off abscess and no frank peritoneal symptoms. Inadvertent catheterization of the colon. After trying to place a drain in an abscess, wait for weeks for the tract to mature, verify by over-the-wire tractogram, and then remove tube. DVT with severe symptoms and no response to systemic anticoagulation equals catheter-directed thrombolysis. 469. SEC110N9 nukes. Tracer analog energy physical half-life I equals T23 equals Odin 1 LL : equals J SI dash I Low minus 81 125 hours, biologic I. E underscore underscore. 1 underscore 33. Underscore 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 TL slash 232nd dot S underscore 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 I. Potassium, low minus 135, 2%, 167.73 hours. L thallium, 201.8%, U71 201 Hg. Underscore daughter RA underscore underscore Y underscore underscore. S underscore 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 underscore. underscore 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 When I say this, you say that. When I say hot clumps of signal in the lungs on liver spleen sulfur colloid, you say too much Al in the TC. When I say hot spleen, you say WBC scan or octreotide, sulfur colloid will be like warm spleen. When I say bone scan with hot skull sutures, you say renal osteodystrophy. When I say bone scan skin with focal breast uptake, you say breast CA. When I say bone scan with renal cortex activity, you say hemochromatosis. When I say bone scan with liver activity, you say either too much Al, amyloid, hepatoma, or liver necrosis. When I say bone scan with sternal lesion, you say breast CA. When I say bone scan with diffusely decreased bone uptake, you say 1 free TC, or 2 bisphosphonate therapy. When I say tramline along periosteum of long bones, you say lung CA. When I say super hot mandible in adult, you say fibrous dysplasia. When I say super hot mandible in child, you say CAFES. When I say periarticular uptake of delayed scan, you say RSD. When I say focal uptake along the lesser trochanter, you say prosthesis loosening. When I say tracer in the brain on a VQ study, you say shunt. When I say tracer over the liver on ventilation with xenon, you say fatty liver. When I say gallium negative, thallium positive, you say Kaposi. When I say high T3, high T4, low TSH, low thyroid uptake, you say K veins, granulomatous thyroiditis. When I say persistent tracer in the lateral ventricles, 24 hours, you say NPH. When I say renal uptake on sulfur colloid, you say CHF. When I say renal transplant uptake on sulfur colloid, you say rejection. When I say filtered renal agent, you say DTPA, or GH. When I say secreted renal agent, you say MAG3. When I say PET with increased muscle uptake, you say insulin. When I say diffuse FDG uptake in the thyroid on PET, you say Hashimoto. When I say I see the skeleton on MIBG, you say diffuse neuroblastoma bone mets. When I say cardiac tissue taking up FDG more intense than normal myocardium, you say hibernating myocardium. I say made with a generator, you say TC99 and rubidium. 475. High yield trivia. Geiger-Müller, maximum dose it can handle, is about 1/H activity level greater than 100 MCI of TC, 99 M is considered a major spill. Activity level greater than 100 MCI of TL, 201 is considered a major spill. Activity level greater than 10 MCI of IN, 111, is considered to represent a major spill. Activity level greater than L0 MCI of GA, 67, is considered to represent a major spill. An activity level greater than 1 MCI of flow, 131, is considered to constitute a major spill. Annual dose limit of 100 rem to the public not greater than 2 rem per hour. In an unrestricted area, total body dose per year equals 5 rem total equivalent organ dose. Skin is also an organ. Per year equals 50 rem total equivalent extremity dose per year equals 50 rem, 500 MSV. Total dose to embryo/fetus over entire 9 months. 0.5 rem NRC allows no more than 0.15 micro CI of MO per 1 milli CI of TC at the time of administration. Chemical purity, Al in TC, is done with pH paper. The allowable amount of Al is 10 micrograms. Radiochemical purity, looking for free TC, is done with thin layer chromatography. Free TC occurs from lack of stannous ions or accidental air injection, which oxidizes. Prostate cancer bone mets are uncommon with a PSA less than 10 mg/ml. Flare phenomenon occurs 2 weeks. 3 months after therapy. Skeletal survey is superior, more sensitive. For lytic mets AVN, early and late is cold. Middle, repairing, is hot. Particle size for VQ scan is 10 to 100 micrometers. Xenon is done first during the VQ scan. Amiodarone, classic thyroid uptake blocker. Hashimoto's increases risk for lymphoma. Hot nodule on TC shouldn't be considered benign until you show that it's also hot on 1123. This is the concept of the discordant nodule. History of methimazole treatment, even years prior, makes 1 to 131 treatment more difficult. Methimazole side effect is neutropenia. In pregnancy, PTU is the blocker of choice. Sestamibie in the parathyroid depends on blood flow and mitochondria. You want to image with PET following therapy at interval of 2 to 3 weeks for chemotherapy, and 8 to 12 weeks for radiation is the way to go. This avoids stunning false negatives and inflammatory induced false positive. 111-IN pentetriotide is the most commonly used agent for somatostatin receptor imaging. The classic use is for carcinoid tumors. 476. Meningiomas take up octreotide prior to MIBG. You should block the thyroid with Lugol's iodine or perchlorate. Left bundle branch block can cause a false positive defect in the ventricular septum. Spares the apex. Pulmonary uptake of thallium is an indication of LV dysfunction. MIBG mechanism is that of an analog of norepinephrine, actively transported and stored in the neurosecretory granules. MDP mechanism is that of a phosphate analog, which works via chemisorption sulfur. Colloid mechanism equals particles are phagocytized by Res. 477. SECT10N10, neuro. This VS that, HIV encephalitis vs PML. HIV encephalitis is symmetric, T2 bright, TL normal, PML is asymmetric, T2 bright, TL dark. This VS that, AIDS infections. AIDS PML CMV encephalitis symmetric T2 asymmetric T2 periventricular bright bright T2 bright. TL dark ependymal enhancement. This VS that, toxo VS lymphoma. Toxo. Ring enhancement. Thallium cold. Cryptococcus. Dilated perivascular spaces basilar meningitis. Toxolymphoma ring enhancing hemorrhage more common, after treatment hemorrhage less common, after treatment thallium cold J thallium hot pet hot Mr. Perfusion. Perfusion, decrease. CBV. This vs that, Lefferts unique. Four hundred. 480. High-yield trivia. The order of tumor prevalence in NF2 is the same as the mnemonic MSME, schwannoma, meningioma, ependymoma. Maldeveloped draining veins is the etiology of Sturge-Weber olfactomatosis, NF1, NF-2. TS and VHL, except Sturge-Weber are autosomal dominant, family screening is a good idea. Most common primary brain tumor in adult equals astrocytoma, calcifies 90% of the time, equals oligodendroglioma restricted diffusion in ventricle equals watch out for choroid plexus xanthogranuloma, not a brain tumor. A benign normal variant, pituitary, TL big and bright equals pituitary apoplexy pituitary, normal TL bright equals posterior part, because of storage of vasopressin, and other storage proteins, pituitary, T2 bright equals rath cleft cis pituitary, calcified equals craniopharyngioma CP angle. Invades internal auditory canal equals schwannoma CP angle, invades both internal auditory canals equals schwannoma, with NF2 CP angle, restricts on diffusion equals epidermoid, PEDS, arising from vermis equals medulloblastoma PEDS, fourth ventricle, toothpaste, out of fourth ventricle equals ependymoma adult myelination pattern, TL at 1 year, T2 at 2 years. Brainstem and posterior limb of the internal capsule are myelinated at birth. CN2 and CNV3 are not in the cavernous sinus persistent trigeminal artery, vertebral to carotid, increases the risk of aneurysm subfalcine herniation, can lead to ACA infarct, ADEM lesions will not involve the callosocceptal interface. Marchia for the bignami progresses from body, genu, splenium post-radiation changes don't start for 2 months, there is a latent period. Hippocampal atrophy is first with Alzheimer dementia most common torch for CMV toxo-abscess, does not restrict diffusion small cortical tumors, can be occult without for contrast JPA, and ganglioglioma, can enhance, and our low-grade nasal bone is the most common fracture zygomaticomaxillary complex fracture, tripod, is the most common fracture pattern and involves the zygoma, inferior orbit, and lateral orbit. Supplemental oxygen can mimic SAH on flare putamen, is the most common location for hypertensive hemorrhage. Restricted diffusion without bright signal on flare should make you think hyperacute. 6 hours, stroke. Enhancement of a stroke, rule of threes, starts at day 3, peaks at 3 weeks, gone at 3 months. 484. R. PEN is the most common systemic vasculitis to involve the CNS scaphocephaly, is the most common type of cranosynostosis piriform aperture stenosis, is associated with hypothalamic pituitary adrenal axis issues. Cholesterol granuloma is the most common primary petrous apex lesion large vestibular aqueduct syndrome, has absence of the bony modiolus in 90% of cases. Octreotide scan will be positive for esthesioneuroblastoma. The main vascular supply to the posterior nose is the sphenopalatine artery, terminal internal maxillary artery. Warthin's tumors take up protectate Sjogren's, get salivary gland lymphoma, most common intraocular lesion, in an adult equals melanoma, enhancement of nerve roots for 6 weeks after spine surgery is normal. After that its arachnoiditis hemorrhage in the cord, is the most important factor for outcome in a traumatic cord injury. Currarino triad, anterior sacral meningocele, anorectal malformation, sarcococcygeal osseous defect. Type 1 spinal AVF, dural AVF, is by far the more common. Herpes spares the basal ganglia, MCA infarcts do not. 485. Section 11, MSK.